كويس.
ماشي اوكي.
الصورة اللي هنا من دي.
بسم الله نبدأ دكتور.
ده
أيوة دكتور بسم الله خلاص.
طيب. بسم الله الرحمن الرحيم. إن شاء الله نبدأ وقائع يومنا الثاني للمؤتمر الطبي السابع لطب الأطفال وحديثي الولادة بالمستشفى السعودي الألماني. Our first session will start today with our eminent speaker, Dr. Mustafa Saeed. Dr. Mustafa Saeed is the professor of dermatology in Al Mansoura University in Egypt, and he is department head of dermatology and cosmetology in Saudi German Hospital Riyadh. Dr. Mustafa will give us a nice talk about a real case was present in our unit in ICU, and he shared with us. The talk will speak about low peri-muffin baby. Think deeply. أهلا وسهلا دكتور مصطفى. شرفتنا.
أهلا وسهلا. Starting, I thank Dr. Nabil and Saudi German Hospital Riyadh admin for this very precious well-known conference. My speak today is about, as Dr. Nabil said, a real case, low peri-muffin baby, think deeply, case presentation, and review of literature. I declare that I have no conflict of interest regarding the material in this presentation. First, I acknowledge the chair of Dr. Nabil Shahada and the NICU team, who is actually their case, Professor Dr. Shahad Farag, Mansoura University, for his collaboration, Dr. Rabi' Al-Sayed, Delta Lab, histopathologist for HE and immunohistochemistry, and Dr. Amira Farouk, SCGH Riyadh Lab Director, for her collaboration. The goal of the speak will be the case presentation, review of literature, definition, etiology and pathogenesis, presentation, diagnosis, and management. The case is a full-term female neonate, 8 days, delivered through normal vaginal delivery for a prime gravida healthy mother with body weight 2.8 kg and Apgar score 8. Referred to SCGH Riyadh in ICU for respiratory distress syndrome and generalized skin rash, thrombocytopenia since birth with platelet count 11 and on platelet transfusion. She received IVIG and intravenous antibiotic, first ampicillin and gentamicin, then shifted to meronam and vancomycin with hypocalcemia. The CNS showed moderate activity, no fits or abnormal movement. Cranial ultrasound showed small cyst is seen at the left thalamo-caudate region, measuring 0.6 multiplied by 0.4 centimeter. Normal Doppler study of intracranial vessel. Mild brain edematous changes, grade 1. MRI brain show right frontal subcortical tiny hemorrhagic spot, shows pluming and small 2 multiplied by 2 millimeter CSF cyst is seen on the left caudothalamic groove, likely old germinal matrix hemorrhage. The chest shows mild tachypnea with respiratory distress and connected to RAM cannula. CT chest showed bilateral pulmonary infiltrations, widely scattered nodules of variable size, as well as mixed parenchymal and subpleural distribution. Parenchymal pulmonary cysts seen at the middle loop at the lingula. The middle loop shows mild reticulation and traction bronchiectasis. Few pleural infiltrates centered on the costal pleural, and evident one is seen opposite the left upper lobe. Thymic gland shows parenchymal heterogeneity by non-homogeneous enhancement and parenchymal areas of hypodense necrosis. Effaced fat planes at both axilla, with suspected bilateral matted nodal masses. Hepatosplenomegaly and other are normal. The conclusion of CT MRI, pulmonary and less evidently pleural infiltration, thymic involvement, lymphadenopathy, and hepatosplenomegaly, mostly systemic disorder, either leukemia or others. Low suspicion of disseminated pulmonary infection for further clinical workup, blood tests, and tissue pathology. Right axillary lymph node histopathology showed course of lymph node with replacement of lymph node architecture by chronic specific granulomatous inflammation formed of giant multinucleated cells surrounded by epithelial cells aggregate, lymphocytes, occasional neutrophils, and a few fibroblasts. Negative for definite malignancy in the submitted specimen. So diagnosis of axillary, right axillary lesion, ultrasound guided through cut needed for biopsy. Picture is keeping with granulomatous lymphadenitis, negative for definite malignancy. The story starts from my consultation. Skin examination shows diffuse blackish and purple papules and plaque with purpuric lesion and crusted papulovesicles. The lesions are consistent with Blue-Perry muffin baby syndromes. Here is a scalp, show seborrheic dermatitis-like lesion, purpuric lesion, disseminated diffuse purplic red-brown papules all over the body, here in the face, chest, upper arms, again in the abdomen, on extremities, lesion in the feet dorsi, lesion on the palms, classic Blue-Perry, reddish brown and purple nodules and papules. Again, in the soles, more focused picture showing purplish papule and the nodules. Dermoscopic examination. Actually, the dermoscopy of Blue-Perry muffin papi is very few in the literature. This dermoscopy of the scalp lesion showing this yellowish brown color means granulomatous infiltration with purpuric spots. The Blue-Perry lesion shows lacunae of purple color with surrounding brownish pigmentation. Again, here, multiple violaceous lacunae and mild brown pigmentation in the center and the surrounding. This is showing like a sunset or eclipse. Okay, here the dark pigmentation in the center and the violaceous vessels on the periphery resemble a solar eclipse over a starry sky with reddish brown color of the vessels. Skin biopsy was done and show the low power view showing epidermal focal atrophy. The dermal shows eosinophilic rich lesion with admixed large Langerhans giant cells, Langerhans cell histiocytes, and the multinucleated giant cell. This is power 10. Also showing rich eosinophil, the pinkish color was admixed with large Langerhans cell histiocytes and multinucleated giant cells. More high power, showing the multinucleated giant cells, and the cells are foamy with eosinophil, admixed large Langerhans cell histiocytosis with abundant pale eosinophilic cytoplasm with ill-defined border, irregular and elongated nuclei, and the multinucleated giant cells. Again, histiocyte cell exhibiting abundant pale eosinophilic cytoplasm with ill-defined body, irregular and elongated nucleoli, and occasional nuclear groove here in the arrow with chromatin and intestinic focal conspicuous nucleoli. So, to confirm that these cells are Langerhans histiocytes, immunohistochemistry was done, showing CD1A positive, showing intense membranous and cytoplasmic staining of CD21, immunostaining typical in Langerhans cell histiocytes. Again, high power, showing intense membranous and cytoplasmic staining of CD1A immunostaining in typical Langerhans cell histiocytes. CD68, it is found only in large multinucleated giant cells and the negative in Langerhans cell histiocytes. S100 shows diffuse positive cytoplasmic staining. It is characteristic also for Langerhans cells, while CD30 is negative, means it is not of lymphoid origin, it is not Hodgkin lymphoma. Also CD21 negative, also excluding lymphomas and other tumors. On 22nd of after 12 days of the baby was sent to intervention radiology for lung biopsy. The baby during lung biopsy developed hemothorax, heart rate decrease with trial to resuscitate. However, unfortunately, the patient died after. So now we have Ploperi-Muffin baby, classic skin lesion, histopathology is classic Langerhans cells, immunohistochemistry shows positive for Langerhans cell histiocytes. The patient show negative VDRL, cytomegalovirus and torch viruses, negative herpes simplex virus type 1 and type 2 by PCR. Blood culture show no microbial growth, and peripheral blood smear show mild normocytic normoclinic anemia with an isopoikilocytosis, some target cells and fragmented RBCs, mild leukopenia and absolute lymphopenia, toxic granulation neutrophil, marked thrombocytopenia is confirmed, and no other abnormalities excluding leukemia. So we have a patient with Langerhans cell histiocytosis showing classic Ploperi-Muffin baby, which is very rare presentation. The most cases are case reports. We have this baby have high definition for risk organ involvement, including hepatosplenomegaly, lymph node, lung, pleural, with hematopoietic involvement, defined as with or without bone marrow involvement, at least 2 of the following: anemia, hemoglobin less than 10 grams per deciliter, not a result of other causes, not iron deficiency anemia, leukopenia, leukocytes less than 4,000 per microliter, thrombocytopenia, platelet less than 100, actually it was low tens, spleen involvement enlargement, more than 2 centimeter low cost margin in the midclavicular line, liver involvement with enlargement more than 3 centimeter. So collectively gathering this data, the patient is finally diagnosed as Langerhans cell histiocytosis, multi-system Langerhans cell histiocytosis with high risk organ involvement. So Ploperi-Muffin skin lesion, negative torch VDRL, lymph node enlargement, hepatosplenomegaly, positive immunohistochemistry for Langerhans cell histiocytosis. So the final diagnosis is multi-system risk organs Langerhans cell histiocytosis. The limitation in our case was we cannot do bone marrow biopsy, and no genetic testing, including BRAF and MEP genes, were done. What is a Ploperi-Muffin baby? By definition, Ploperi-Muffin baby is first coined by pediatricians to describe continuous manifestation of congenital rubella observed in newborn during the American epidemic of 1960. It is a rare characteristic eruption in neonate, often present at birth, wherein the baby present with widespread, discrete, non-planchable, purple or erythematous macule, papule, or nodules over the trunk, head, neck that signifies present dermal erythropoiesis resembling a blueberry muffin. This is the blueberry muffin. All of us eat it, and this is the baby. This is the lesion in the abdomen, violet or purple, red, papule, nodule. In the palms, exactly like our case. Even our case was more evidence than these photos. The blueberry muffin baby in neonates collected in 3 groups, disseminated, cutaneous extramedullary hemopiosis, neoplastic infiltration, and vascular lesions. This is a table for infection, including torches, and the AS for syphilis and herpes, dermatologic, hemangiomas, blueberry, Philippe-Nevers syndrome, multifocal lymphangiosylleumatosis, glomerulonephritis, neoplastic, congenital leukemia, neuroblastoma, congenital rhabdomyosarcoma, histiocytosis. Hematologic, blood discrepancies disseminated. The patient was actually A positive, disseminated intravenous coagulation, transient myeloproliferative disorder, mastocytosis, and hereditary spherocytosis. This is the torch, toxoplasmosis, other infection, including syphilis, parvovirus, rubella, cytomegalovirus, herpes simplex virus. Our case was negative for this, was negative for leukemia, evidenced by the CPC and the blood smear, and negative for other infections. The differential diagnosis of blueberry muffin baby include disseminated extramedullary hematopoiesis, again including congenital torch infection, toxoplasmosis, other virus, Coxsackie virus, parvovirus, rubella, cytomegalovirus, severe hemolytic anemia, congenital spherocytosis, rhesus hemolytic disease, APO incompatibility, other causes of severe anemia, twin-twin transfusion, chronic fetal-maternal hemorrhage, severe internal bleeding, congenital leukemia or myelodysplasia. The neoplastic infiltration, including congenital leukemia cutis, transient myeloproliferative disorder, neonatal neuroblastoma, congenital alveolar rhabdomyosarcoma, infantile myofibromatosis, multifocal infantile hemangiomas. So our case is histocytosis, multi-system histocytosis with risk organs presenting as blueberry muffin baby. So what's histocytosis? Histocytosis is defined as a group of disorders characterized by pathological accumulation of cells derived from the monocyte, macrophage, and dendritic cell lineage. More than 100 different subtypes have been described, share a common CD34 positive progenital cells in the bone marrow. Here is the origin, showing the stem cell and the differentiation up to dendritic cells. There is an old classification of histocytosis dating from 1985 to 2016, including Langerhans histocytosis, Hanschler-Christian, eosinophilic granuloma, Littré-Sewe disease, congenital self-healing reticulohistocytosis, Hashimoto-Britziker, non-Langerhans histocytosis related, juvenile xanthogranuloma, other, and malignant histocytosis. We'll speak a very few hints about this. Littré-Sewe disease, this is acute and progressive. From the start, the patient showing the seborrheic dermatitis-like and napkin area lesion. The first, according to the old classification, we should say Littré-Sewe disease occurs from birth to 2 years of life. Cutaneously, a papulosquamous eruption, clinically resembling seborrheic dermatitis, occurs on the scalp, flexural area, and the trunk. Erosion and ulceration frequently of the mucocutaneous areas, pulmonary, hepatic, and splenic involvement may occur. This is the seborrheic dermatitis-like and papule in the scalp. Here is the napkin dermatitis-like and other papular lesion in the inguinal and crural area. The second is Hand-Schiller-Christian disease. It's chronic, progressive, typically occurs in children from 2 to 6 years of age. Cutaneous findings are similar to literacy disease. Triad of osteolytic defects, diabetes insipidus, and exophthalmos. Here, Hand-Schiller-Christian, born and di-Christian. Born include sound like bone. D, diabetes insipidus. E, exophthalmos. This is bone lytic lesion, exophthalmos, and diabetes insipidus. Eosinophilic granuloma, most common form of Langerhans cell histiocytosis. Localized form usually occurs in patients from 7 to 12 years of age. Frequent bone involvement and frequent skin involvement. And finally, congenital self-healing reticulohistiocytosis, typically present at birth with widespread cutaneous involvement lesion, generally involute over a few weeks. So according to the old classification, it is a literacy disease, but according to the new classification, it is a multi-system reticulohistiocytosis with risk organs. This table showing it is from our Holy textbook, Bologna, the 4th edition, 2024. Langer literacy disease, 0 to 2 years, scalp, flexure, area, trunk, visceral, and bone. Hand-Schiller-Christian disease, 2 to 6 years, scalp, flexural area, trunk, gingiva, triad, diabetes insipidus, lytic bone lesion, and exophthalmos. Marked hepatosplenomegaly. Eosinophilic granuloma, 7 to 12, skin lesion, rare, bone lesion primary. Congenital self-healing reticulohistiocytosis, congenital, widespread, localized or single lesion, spontaneous resolution of care. Here is the photo showing most of the presentation. So congenital histiocytosis is a general imitating disease. Could be like cradle cap, could be like eczema or seborrheic dermatitis, could be scarlet fever-like maculopapular rash, could show ulceration of the mouth and buccal mucosa, could be thrombocytopenic purpura. So a great imitator of different diseases like syphilis. Here again, solitary nodular lesion, vesicular and vascular eruption, diaper eruption-like, particularly in the inguinal fold, cradle cap, seborrheic dermatitis-like, and skull lytic lesion of bone. So the recent classification is defined by Emil et al. 2016. It contains 5 categories of histiocyte. The classification is based on clinical manifestation, imaging, histology, molecular and genetics, MAPK, MAPK, pathway mutations. It is published in the Blood, had a review article in 2016. Revised the classification of histiocytosis and the neoplasms of the macrophage dendritic cell lineage. It is defined in 5 groups: Langerhans cell histiocytosis, cutaneous and mucocutaneous C, non-Langerhans cell for skin and mucosa, malignant, Rosay-Dorfman, and miscellaneous, R, hemophagocytic and lymphohistiocytosis, and mass macrophage activating syndromes as H. This is again LCMRH, the new classification. And according to the system affected, it defined in single system, unifocal or multifocal, multi-system, more than 2 organs without risk organs, which these risk organs including liver, spleen, bone marrow, and multi-system with risk organs, more than 2 organs, at which this classification 3 multi-system with risk organs for our case. Again, this is according to the Histiocyte Society, Langerhans cell histiocytosis, single system, multi-system, single system, unifocal, multifocal, multi-system with risk organ, without risk organs. Again, this is the clinical classification: multi-system, single, pulmonary, CNS, multi-system Langerhans cell histiocytes without risk organs, without liver, spleen, and lung. Gonads and kidneys are usually spared. This is the definition of risk organ involvement we spoke about in the presentation of our case. The pathobiology of our current concept of Langerhans cells, there is a debate, but however, it is almost to be defined. is considered as inflammatory myeloid neoplasia driven by activating mutation in the MAP mitogen activated protein kinase pathways. Why neoplastic? Because there is definition of oncogenic activating mutation pathway and demonstration of clonal CD1 positive histocyte in the tissue tested. So detection of clonal CD1A positive histocytes in all Langerhans cell tissue tested, detection of BRAF V600E mutation in 57% of Langerhans cell histocyte specimen, and detection of BRAF mutation in a CD34 positive bone marrow cells of patient with high risk Langerhans cell histocytosis, provide that Langerhans cell histocyte may be derived from hematopoietic progenitor cells. Genetic predisposition in few cases, there is hereditary cases, no primary immune abnormality or viral causes, role of cytokine as interleukin-1, tumor necrosis factor, interferon, granulocyte, monocyte, colony-stimulating factors, promote various disease-related symptoms and morbidity, and not responsible for development of the disease. This is again the pathobiology current concept. Is activating mutation in mitogen activated protein kinase pathway. Okay, again, the BRAF mutation in single system and multi-system are associated with BRAF mutation. Multi-system mutation arise in early myeloid precursors, so it affects more than many organs. Single cell, single organ mutation occurring at later stages of differentiation, so specific few organs, one organ or one focal is affected. The treatment of Langerhans cell histocytosis, it is still a matter of need agreement and consensus. So in 2021, there is a consensus of Langerhans cell histocytosis. It includes for local Langerhans cell histocytes. Treatment options depend on the size and extent of disease. Isolated skin lesions sometimes resolve spontaneously with topical steroid or with oral immune suppression, methotrexate or hydroxyurea. Single bone lesion in readily accessible and non-CNS risk sites may be treated with curettage or steroid injection. Notably, unlike other pediatric cancer, Langerhans cell does not require complete excision with clean margin. In fact, extensive bone resection can impair bone remodeling. When there is systemic affection, like our case, so we have first-line therapy. Multiple lesions indicate potential for remote clonal progenitors. Patient with multiple lesions, therefore, typically require systemic chemotherapy. The current standard for care for initial therapy is vinblastine, prednisone for 1 year, with mercaptopurine added for high-risk Langerhans cell histocytosis based in Histocyte Society Langerhans cell trial. The salvage therapy includes nucleoside analog, high doses of cytarabine. Cladribine was effective but associated with significant treatment-related morbidity and mortality. Targeted therapy, this is the new therapy, MAP pathway-directed targeted therapy with BRAF mutation or MEK inhibitor. MAP inhibitors with chemotherapy or oral anti-apoptotic organ or epigenetic modifier to safely cure patients with Langerhans cell-related disorders. The BRAF inhibitor mostly used is vemurafenib, zilporaf tablet, rapid clinical improvement of severe refractory Langerhans cell histocyte within a few days. Dabarafenib, tafinlar capsule, or combinatinib. And this is the very last new study about dabarafenib and tramitinib in Langerhans cell histocytosis and other histocytic disorder in April 2024. The reference is our Polenia to 2024 cutaneous histocytosis. Others are listed here. So finally, In a case of blueberry muffin baby, it is not simple. We should exclude the torch and other viral infection. We should exclude leukemias and other hematologic malignancies. And finally, main part is to do biopsy from any lesion, either tissue biopsy from the liver, spleen, lymph node, lung, pleura, and more easily and more simply from skin. The key of our case was skin biopsy with hematoxylin eosin and immunohistochemistry with exclusion of other causes. So our case finally is multi-system Langerhans cell histocytosis with risk organs presented as blueberry muffin baby. Thanks a lot. Thank you.
Mute. Thank you so much. Mustafa. So it's clear? Yes. Okay. Thank you, Dr. Mustafa, so much for your nice presentation. This case teaches us a lot because it started with us with just a body rash. And when we consulted Dr. Mustafa, actually he is the one thought in this direction, would have never thought about this. And this give us a good lesson to consult everyone in his subspecialty, even if you see that it is just a rash and it will not help much, and maybe also dermatology will not help. No, everything will help, especially if you are considering or speaking with a scientific professor. So Dr. Mustafa was a real great help for us, because this case maybe she would have died without any diagnosis and without reaching to anything other than preterm baby and infections and repeated infections like this. So again, thank you, Dr. Mustafa, for your nice presentation and for your great help to the NICU department. Our next speaker will be Dr. Samira Ghallab. Dr. Samira Ghallab is consultant neonatologist and pediatric, but actually she is neonatology for most of the time with us. She will give us an interesting topic about some interesting cases from our unit. So the presentation will be a real case. Okay, Dr. Samira.
طيب بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم.
شوف الصوت الأول كويس. الصوت كويس كده؟
تمام تمام دكتور تمام.
أستاذ علاء الصوت واضح
تفضلي.
عندك؟
تمام تمام دكتور، تفضلي دكتور سميرة،
أستاذ
تفضلي.
علاء
تمام دكتور، سامعتيني؟ دكتور علي الصوت عندك دكتور. دكتور
مش ولا. أستاذ علاء، مستر علاء.
دكتور
طيب
دكتور سامعتيني؟
يلا.
لا. السلام عليكم ورحمة الله وبركاته. I will present.
ألو. طيب علي الصوت عندي. لا هم سامعينك بس علي الصوت بتاعك انت كمان بس قفل الصوت انت. علي الصوت.
دكتور سامعتيني حضرتك؟
يلا.
طيب
يلا هم سامعينك يلا.
ماشي
تمام دكتور؟
أيوه تمام كده.
تفضلي تفضلي حضرتك.
السلام عليكم ورحمة الله وبركاته.
وعليكم
I
السلام.
will present for you a clinical case starting with history, clinical examination, and investigation as usual. Then I will show how we reach the diagnosis, and I will give a hint about the diagnostic, the diagnosed disease for this case. Our patient was a female preterm 30 weeks gestation, was born via CS for a 30 years old gravid 3/3 mother. This mother has been for 48 hours, and she received prophylactic antibiotics with no other clinical issues regarding the medical history of the mother. The baby cried immediately after birth, but then she developed secondary apnea. Resuscitation was done, and the infant was stabilized. Our score was 5, 7, and 8, and 9 at 1, 5, and 10 minutes. The birth weight was 1.4 kg, and the length was 39 cm, which were just below the 50 centile, which are adequate for the gestational age. After stabilization, the patient had respiratory distress syndrome, and she received surfactant. And on examination, she has subtle dysmorphism. She had normal female genitalia, and there was no other in-skin hyperpigmentation or deformities, with normal abdominal and cardiac examination. She was connected to mechanical ventilation, then weaned gradually early, and she reached room air within the first 2 weeks of life. On investigations follow-up for the patient, she had severe hyperkalemia, hyponatremia with metabolic acidosis and severe polyuria. The serum potassium from the first 24 hours reached about 8.1 millimole per deciliter and was treated with inhaled salbutamol, insulin and glucose infusion, bicarb, and calcium gluconate. The sodium also started to decrease from after the second day of life and reached in its lowest level to 112 millimole per liter and was treated with 3% sodium chloride. The polyuria reached 13 ml per kg per hour, which is severe form of polyuria, and the serum creatinine and the urea through this time was increased, which indicates the renal impairment, and mostly due to the dehydrations this patient was having, because these are corrected after the correction of the fluid balance. The renal ultrasound we did early in life and was done and did not show any urinary tract malformations or any other abnormality in the abdomen. Here we send for renin and aldosterone level, where the result came back after days to be very high for both of them. Through that, the blood pressure and the RBS were normal. The patient didn't receive any inotropic support and didn't have any attacks of hypoglycemia. We did also other investigations, including the hormonal investigations, cortisol and 17-hydroxyprogesterone, which were normal for the patient. To summarize the condition until now, we have a preterm with history of unexplained polyhydramnios with severe hyponatremia, hyperkalemia, polyuria, metabolic acidosis, normal blood pressure, normal blood glucose, and with high level of aldosterone and renin. And this means that there is no response to the aldosterone action. And here we are giving the diagnosis of pseudo-hypoaldosteronism. Regarding the septic workup, initially we did the blood culture, which showed negative results, and the inflammatory markers were negative. After a few days of birth, we did the urine culture as a screening for urinary tract infection because of these electrolyte disturbances, and the urine culture came back negative. But after 2 weeks of age, the patient developed signs of urinary tract infections, and the urine culture showed growth of Pseudomonas aeruginosa, which was treated by the adequate antibiotics, and this was hospital-acquired infection due to urinary catheterization and urine catheter-associated bacterial infection. The baby received feeding and tolerated early, and there was need for long-term to administer IV fluid for correction of the electrolytes and the replacement of the polyuria to adjust the hydration status of the patient. After that, the electrolytes started to show some improvement, and we sent the serum renin and aldosterone again, which showed starting to drop both of them. The aldosterone decreased from 132 picogram to 39.6, and the renin dropped from 550 to 118. And on follow-up of the electrolytes from the age of 2 months of age and through the 3rd month of life, there was normal electrolyte levels and normal urine output with no infusions or replacement needed. We sent also extended metabolic screening, which was normal, and the patient planned for genetic study, but unfortunately the parents refused the genetic workup. This chart is showing some of the electrolyte results, especially through the first week of life, and the renal function and how it improved after correction of the hydration status. In conclusion, we have a preterm with unexplained polyhydramnios on the antenatal ultrasound. The patient developed postnatal polyuria, dehydration, metabolic acidosis, hyperkalemia and hyponatremia, normal blood pressure and blood glucose, despite of the very high levels of aldosterone and renin, with no renal malformation and no urinary tract infection. And as I told, the urinary tract infection the patient had was due to it was a catheter-associated infection. The condition showed improvement on follow-up with supportive management, and the levels of aldosterone and renin were decreasing on follow-up. Based on the clinical and laboratory studies, we put the diagnosis for the patient of transient infantile pseudo-hypoaldosteronism. The patient was discharged at the age of 42 weeks plus 4 days corrected gestation with weight of 1.8 kg, and unfortunately we didn't have the chance to follow the patient because they moved outside the Saudi Arabia. I will discuss here about some hints about the disease itself. As we know, the aldosterone is the primary hormone involved in the regulation of sodium and potassium, and it is essential for sodium retention in the kidneys, salivary glands, sweat glands, and colon. And infantile pseudohypoaldosteronism is a rare disease of infancy characterized by an apparent state of renal tubular unresponsiveness or resistance to the action of aldosterone. The pseudohypoaldosteronism is classified to type 1 and type 2. Type 1 is subclassified to primary and secondary, and our category is the secondary type, which named also the transient pseudo-hypoaldosteronism, which may be explained by low renal mineralocorticoid receptor expression and physiological partial aldosterone resistance, which will be more severe with the gestational prematurity. And that is why this case is usually occurring in the first 6 months of life. Most of the reported cases are patients having urinary tract infections or structural urinary tract malformations, and rarely with gastrointestinal losses. Our patient here doesn't have any of these, but she has only the prematurity. Clinically, this disease is giving the clinical picture of the cause. So if there is kidneys in the kidney, if there is any abnormality in the kidneys, signs of urinary tract infection, bacterial toxins, malformations, GIT, we can find vomiting, abdominal distension, diarrhea, or losses from the ileostomy, and the prematurity itself. These patients will have dehydration, and they have electrolyte disturbances in the form of hyponatremia, hyperkalemia, metabolic acidosis, and may have ECG abnormalities due to the electrolyte disturbances, which may lead later on to cardiac arrest if not treated. There is also high aldosterone level with elevated or sometimes normal renal activity. The differential diagnosis of transient pseudohypoaldosteronism should include all the diseases causing shock, especially the cardiogenic shock, which can happen from the arrhythmia, and the hypovolemic shock, which could be happening from the hypovolemia, causes of hyperkalemia, causes of hyponatremia, and the causes of vomiting. The most important diseases in this age group, we should put in the differential diagnosis during our workup, is the other types of pseudohypoaldosteronism, congenital adrenal hyperplasia, Bartter syndrome, Gentleman syndrome, and pyloric stenosis. Bartter or Gentleman syndrome, these are associated with polyuria, but the potassium is low, sodium also is low. Congenital adrenal hyperplasia, there is hyperkalemia and hyponatremia, but the aldosterone is not, the condition is not high. The treatment is mainly the treatment of the electrolyte disturbances and metabolic status with rehydration of the patient, and plus treatment of the underlying cause. So one can be IV antibiotics for the urinary tract infection or surgical correction of the urinary tract malformations. Regarding the prognosis, these patients usually have spontaneous recovery with time, and if there is improper treatment of the conditions, the complication could occur, including the complications of the electrolyte disturbances from the arrhythmia and dehydration. That is, both of them can causing, as I told, the cardiogenic or hypovolemic shock. And this patient can reach to cardiac arrest and death from the electrolyte disturbances. And it is important for this patient on the follow-up for monitoring of aldosterone, electrolytes, blood gas, and body weight for at least 1 year after discharge, because these cases can recur. My message in this is my last slide. Transient infantile pseudohypoaldosteronism is a rare condition, may be presented with unexplained antenatal polyhydramnios, which may be explained by the polyuria intrauterine. It needs supportive but targeted and urgent treatment to avoid the complications of electrolyte disturbances. Prematurity is an important cause. Maybe it is the only cause present for these cases, besides also the UTI, renal malformations, and rarely the GIT losses. Outcome is generally good, but needs long-term monitoring and follow-up. This is my last slide, and thank you. Stand up.
Thank you so much, Dr. Samira, for your nice presentation. Our next speaker Associate Professor of Pediatrics in my clinic college of she's a consultant here.
دكتور نبيل صوتك مش طالع.
مش طالع؟ كده كويس ولا ايه؟
عم بيقطع.
كده هو نص تمام. كده كويس؟
تفضل دكتور.
كده الصوت واصل ولا ايه؟
ضعيف والله يا دكتور.
انا مش عارف كده مش افصل بس كده سامعني؟ طالع الصوت واضح كده؟
دكتور الصوت مسموع بس ضعيف.
طيب معلش افصل وادخل تاني بصوت اللابتوب تاني خارجي لو مش واضح قوي افصل وادخل تاني لو واضح هعدي الدكتوره زي وبعدين افصل.
لا دكتور الصوت مش واضح ابدا، مش مفهوم كل الكلام.
طيب كده احسن؟
نعم كده احسن.
كده الصوت واضح؟
نعم دكتور نعم.
طيب اوكي. Thank you Dr. Salim for your nice presentation. Our next speaker will be from USA, دكتورة زانا بومبا. دكتورة زانا is Associate Professor of Pediatrics and Adolescent Medicine in the College of Medicine. She is a consultant in the Department of Pediatrics and Adolescent Medicine. Dr. Jana will speak to us about early strategy of BBD in extreme preterm infants. Welcome, Dr. Jana. You have the can start.
Good afternoon, good evening.
Good evening. Welcome. You can start, share your screen, and you can start.
So greetings from Mayo Clinic in Rochester, Minnesota. My name is Jane Brembaugh. I'm a neonatologist, as well as the Vice Chair of Research for our Division of Neonatal Medicine. My goal in the next half hour is to discuss the strategies for bronchopulmonary dysplasia, or BPD. I have nothing to disclose and no conflicts of interest to resolve. First, we will characterize BPD. Then we will cover the management of BPD from a nutritional, ventilatory, and pharmacologic perspective. In the United States, we have an idiom that a picture is worth 1,000 words. So let's begin with a couple of pictures to set the stage. Here are 3 chest radiographs of an infant born at 22 weeks of gestation. Currently, this is the lower limit of gestational age at which we offer newborn resuscitation at Mayo Clinic. On day 1, there are bilateral ground glass opacities that are classic for respiratory distress syndrome. However, by the end of the first week, the radiograph is often more patchy, less homogeneous, and the lung disease frequently is not responsive to surfactant, with early evidence of either ventilator-associated injury or developing BPD. Bronchopulmonary dysplasia sometimes is described as 2 diseases with one name. The classic BPD from the 1980s and early 1990s resulted from ventilator-induced lung injury, inflammation, fibrosis, and cystic changes. Newer BPD that we more frequently manage in our neonatal intensive care units results from disrupted lung development with fewer alveoli, decreased septation, and less developed pulmonary vasculature. We've witnessed this change over the last 30-some years due to younger gestational ages at birth, gentler ventilation approaches, widespread antenatal corticosteroid use, and surfactant availability. When we look under the microscope at lung sections of a 5-month-old infant born full term on the left, compared to an infant born preterm who has BPD at 5 months corrected age on the right, we can see that the lungs on the right of the infant with BPD have enlarged alveolar ducts and fewer alveoli for gas exchange. Before we dive deep into the early management of BPD, let's take a minute to define what it is. BPD is a disease process affecting infants born preterm who require ongoing respiratory support at 36 weeks post-menstrual age. This stems from the evidence-based definition published in 2019 by Eric Jensen and colleagues in the Neonatal Research Network. They evaluated 18 potential definitions of BPD to predict death or serious respiratory morbidity at 18 to 26 months corrected age. The definition with the best predictive value of death or serious respiratory morbidity did not include FiO2 or the duration of supplemental oxygen use, which historically have been used in defining BPD. The evolving definition of bronchopulmonary dysplasia is necessary because the modalities with which we manage BPD are changing. Historical definitions do not account for the infants on high-flow nasal cannula or nasal CPAP with no supplemental oxygen need. However, this evidence-based definition remains limited in that the disease process continues to be classified by a treatment modality and not by the underlying pathology. BPD manifests in different ways, and while we often focus on the parenchymal lung disease component, pulmonary vasculature involvement and large airway disease are major factors in the more severe form of BPD, that is grade 3 BPD. Ventilator-associated injury superimposed on immature lungs is frequently cited as the culprit for bronchopulmonary dysplasia. In reality, BPD stems from multiple factors in addition to volute trauma and barotrauma. There's the imbalance between antioxidant defenses and the production of radical-free oxygen. There are also maybe a history of antenatal infection, fetal inflammatory response, genetic contributions, growth restriction, or nutritional deficiencies. There remains a subset of infants with BPD who are enigmatic. These are infants born very preterm who initially have minimal lung disease, but develop increasing oxygen and ventilatory needs over the first several weeks of life. A reason that infants with minimal lung disease early on may progress to BPD is fetal exposure to inflammation, altered growth potential, and other antenatal factors. That brief overview of what is bronchopulmonary dysplasia, let's shift to discuss how to manage early BPD, beginning with nutritional approaches. This slide highlights a few concepts for why I'm leading with nutrition when discussing the management of bronchopulmonary dysplasia. First, both intrauterine growth restriction and small for gestational age status are risk factors for BPD. Infants with a history of either may have abnormal pulmonary vascular angiogenesis, chronic fetal hypoxia, increased airway resistance, or limited stores of essential nutrients involved in lung injury and repair, such as vitamins A and E. The second reason I'm beginning with nutritional strategies is that undernutrition and postnatal growth failure will impact the ability of the infant to resist cell damage, fight infection, and promote lung growth. As a result, inadequate postnatal nutrition can lead to delayed somatic growth, delayed alveolar development, and abnormal lung healing. Children with BPD who demonstrate catch-up growth or above average growth measured by weight gain have greater longitudinal improvement in pulmonary lung function testing compared with children with bronchopulmonary dysplasia who have average or below average weight gain. We also know that linear growth is associated with improvement in lung function in children with BPD, even more so than weight gain. Lack of adequate nutrition can impair immune system function and predispose infants to infection. Respiratory infections and the associated inflammation exacerbate lung injury in infants with BPD. For these reasons, it is critical to consider nutrition as central to the management of BPD. Infants with BPD require more total energy intake than age-matched controls without BPD, likely secondary to increased workup breathing and increased metabolic demands. This occurs in grade 3 BPD, but this increased energy need also can be seen in the convalescing infant with lower grade BPD who is working to establish full oral feedings. Infants with bronchopulmonary dysplasia may require more than 120 kilocalories per kilo per day, especially in the acute phase of the disease. Despite the need for increased energy intake, infants with BPD may receive inadequate nutrition during periods of clinical instability. This can occur secondary to frequent discontinuation of enteral feedings during periods of acute illness and chronic fluid restriction affecting nutrient delivery. Monitoring the weight for length ratio is important to identify abnormal growth patterns. Increasing weight gain velocity out of proportion to linear growth velocity may be indicative of edema or a significant decrease in energy expenditure, the latter of which necessitates adjustments to an infant's nutritional plan. Mid-upper arm circumference measurements may help differentiate edema from true weight gain, as the upper arm is less affected by fluid status than other body regions. It is also important to consider that optimal weight and linear growth rates change as the patient ages. In most scenarios, a 6-month-old infant should have a slower rate of growth than a 2-month-old infant. So let's talk about how we should feed infants who are at risk of BPD or who have established BPD. Enteral feeding is preferred over parenteral nutrition and should be prioritized even in the setting of acute illness when feasible, such as during pulmonary disease exacerbations and periods of sedation or paralysis. Why? Parenteral nutrition places the infant at risk for central line-associated bloodstream infections and parenteral nutrition-associated cholestasis. Whether infants receive gastric feedings or post-pyloric feedings remains debated. Arguably, gastric feedings are physiologic and may be preferred. Human milk is recommended as the preferred source of nutrition, including for infants born preterm. Maternal milk offers many protective benefits, has been associated with a lower incidence of necrotizing enterocolitis, and may be associated with a lower risk of developing lung disease. A study of infants with established BPD demonstrated that those receiving long-term maternal milk had fewer systemic corticosteroid courses, fewer emergency room visits, and a lower risk of readmission. Note that preterm infants with BPD require fortification of human milk to provide the essential nutrients for catch-up growth and bone health. If human milk is not available, preterm infant formulas are recommended because of their higher concentration of protein, minerals, and vitamins. And as the infant nears term age or shortly thereafter, post-discharge formulas can be used as they contain more energy, protein, minerals, and vitamins compared with typical term infant formulas. Besides thinking about the severity or grade of BPD, it is useful to consider the phase of lung disease progression. There are different nutritional needs depending on whether an infant is in the acute, chronic, or resolving phase of BPD. The acute phase of BPD is characterized by physiologic instability, high oxygen needs, increased work of breathing, frequent desaturations, and poor neuroregulation. The second, or transitional chronic phase, is characterized by slow weaning of supplemental oxygen, improved work of breathing, brief periods of quiet alertness, and emerging tolerance of activities. The third, or prograde resolving phase of BPD, is associated with stable oxygen requirements, comfortable work of breathing, and the ability to wean respiratory support. Changes in growth patterns may be observed in the different phases. The nutritional needs vary across the phases and interplay with the infant's age-associated needs. For example, older infants have lower fluid needs than younger infants. The lower fluid goal in the pro-growth phase does not reflect fluid restriction, but rather tailoring for an infant's age and disease stage. In the next section of this presentation, we will focus on ventilatory approaches for the care of the infant at risk of developing bronchopulmonary dysplasia, as well as the infant affected by BPD. First, the most potent intervention to prevent bronchopulmonary dysplasia is to prevent preterm birth. However, if preterm birth cannot be avoided, as is often the case today, there are care approaches that reduce the risk of BPD. Beginning in the delivery room, continuous positive airway pressure compared with intubation, early selective surfactant administration compared with delayed surfactant, vitamin A, volume-targeted ventilation compared to pressure-limited ventilation, and high-frequency ventilation compared to conventional ventilation all are associated with a reduced risk of BPD, with a number needed to treat less than 30 for each individual intervention. Once BPD occurs, however, the optimal ventilator strategy required by the affected infants is dramatically different than the strategy utilized early in life for respiratory distress syndrome. The ventilator strategy must reflect the transition from lung mechanics observed in the first few days of life to the mechanics seen in established BPD. In the first week, the lung mechanics of respiratory distress syndrome, that is low compliance with relative homogeneity, support a ventilator strategy with a fast rate, low tidal volume, and short inspiratory time. In established BPD, there's high airway resistance. The lung is heterogeneous, with different characteristics across different lung regions, which leads to variable time constants. To enhance gas exchange and decrease dead space ventilation in BPD, the ventilator strategy needs to change to incorporate a slower rate, larger tidal volume, and more prolonged inspiratory time. While volume-targeted ventilation may help prevent BPD, whether the use of volume-targeted or pressure-limited ventilation is best with established BPD is uncertain. The targeted tidal volume for infants with developing obstructive airway disease may be 8 to 12 milliliters per kilogram in developing BPD. The peak inflation pressure needed to generate this tidal volume can exceed 30 centimeters of water. These high pressures reflect the need to provide sufficient volumes in lung disease characterized by high resistance, increased inspiratory time, and increased tidal volume requires the use of a slower ventilator rate to allow for sufficient emptying to avoid hyperinflation and gas trapping. Monitoring the flow waveforms can aid in determining whether expiratory flow has been completed before the next breath is delivered. Although counterintuitive in the setting of hyperinflation, positive end-airway pressure, or PEEP, should be relatively high, 6 to 8 centimeters of water, at a minimum to optimize gas exchange, maintain the functional residual capacity, and avoid atelectasis. In some patients with airway collapse due to tracheomalacia or bronchomalacia, PEEP may need to be higher still to keep the airways open during exhalation. Unfortunately, we lack clinical trials to validate the strategy described of low rate, large tidal volume for BPD. Rather, this strategy is grounded in clinical experience of centers with BPD expertise and the current understanding of the pathophysiology of BPD. Finally, let's spend a few minutes on the pharmacological approach to bronchopulmonary dysplasia management. Beyond what we feed infants, there are additional pharmacological and fluid management decisions that interplay and affect growth for infants affected by BPD. Over the years, systemic corticosteroids have been used in both the prevention and management of BPD. Corticosteroids, when administered systemically, have a negative impact on linear growth and cause lower weight gain velocity independent of energy expenditure and energy intake. Corticosteroids affect growth at the cellular level by increasing protein catabolism and reducing protein accretion. They also alter lipid and bone metabolism. Diuretic therapy is commonly used in BPD to manage pulmonary edema, yet prolonged diuretic use can result in chronic electrolyte derangements that have a negative effect on growth and bone mineralization. Fluid restriction in BPD remains commonplace practice in many centers, despite the lack of high-quality evidence to support it. The rationale tends to be that higher fluid intake may contribute to pulmonary interstitial emphysema and lower lung compliance. While many centers prescribe fluid restriction, especially during the acute phase of BPD, it is important to maintain normal serum electrolytes, as well as ensure the delivery of sufficient calories and protein. And I'd posit that fluid restriction may not help in the absence of an acute exacerbation of pulmonary edema. Let's take a step back in time for context with respect to the role of corticosteroids for BPD. In 1983, dexamethasone was reported to decrease the need for ventilatory support in a study of just 6 infants. There was a body of evidence that developed into the 1990s which supported the observation that infants' ventilatory needs decreased upon receiving dexamethasone. With the limits of viability lowering, prophylactic steroid courses became common in an effort to prevent bronchopulmonary dysplasia. And by 1997, over half of infants with birth weights less than 750 grams received postnatal corticosteroids. However, in the late 1990s, childhood outcomes of the infant recipients of prophylactic high-dose corticosteroids became available. The study described here by Ye et al. Is one of the studies that showed a higher likelihood of an abnormal neurological examination or cerebral palsy in children born preterm who received dexamethasone early on as infants. We subsequently learned that the effect of postnatal corticosteroids on the combined outcome of death or cerebral palsy varied with the level of risk for bronchopulmonary dysplasia. This is a now classic figure from 2005 that showed if the risk of BPD was less than 35%, postnatal steroids were associated with an increased risk of death or cerebral palsy. However, if the risk of BPD exceeded 65%, postnatal corticosteroids were associated with a reduced risk of death or cerebral palsy. The underlying principle holds true 2 decades later. That is, the possible benefits of postnatal corticosteroids depend on the risk of BPD. For infants at high risk of BPD, the benefits of postnatal corticosteroids may exceed the risks. So where are we now for steroids and BPD? The 2023 Cochrane Review on Corticosteroids for the Prevention of BPD analyzed 16 studies. It concluded that the evidence was uncertain about the effects of different corticosteroid regimens on mortality, pulmonary morbidity, and the long-term neurodevelopmental impairment risk. There were no conclusions drawn regarding the optimal timing, type, or dose of corticosteroids for the prevention of BPD. Only 1 year later, the 2024 Cochrane Review on Corticosteroids for the Prevention and Treatment of BPD analyzed 9 systematic reviews that included 87 randomized controlled trials. It concluded that late dexamethasone, that is dexamethasone administered 7 days after birth or later, is an effective intervention to reduce the risk of BPD in infants with a high-risk profile for BPD. It also concluded that early systemic dexamethasone and hydrocortisone in the first week of life, as well as late hydrocortisone after 1 week of age, were ineffective for BPD based on an unfavorable risk-benefit profile. What about other formulations of steroids that may avoid the adverse systemic effects? Early inhaled corticosteroids may have a beneficial effect on BPD. An endotracheal instillation of budesonide with surfactant as a carrier may be a promising intervention. However, more studies are needed for both inhaled and endotracheal instillation of corticosteroids. So let's summarize the key points covered for the management of bronchopulmonary dysplasia. First, with respect to nutrition, treat nutrition as central to the management of lung disease. Tailor nutritional targets based on the infant's individual lung disease, growth trajectories, and age. As for systemic corticosteroids, late dexamethasone therapy after 1 week of age often is reserved for infants who remain ventilator dependent, and when utilized, monitor for response. Dexamethasone may be discontinued if no beneficial pulmonary response within 2 days of initiation. In our practice, we often wait until 2 weeks of age. Avoid chronic diuretic use for BPD routinely, given the lack of evidence as well as potential adverse effects. Rather, reserve diuretic use to acute episodes of pulmonary edema in infants with BPD. With respect to mechanical ventilation, provide non-invasive support in the delivery room when possible. When surfactant is indicated, consider continuing non-invasive support with surfactant administration via less invasive surfactant administration, or ensure with intubation, surfactant administration, subsequently followed by extubation. During invasive mechanical ventilation, allow permissive hypercapnia. Use a volume-targeted mode of ventilation with pressure support for spontaneous breaths if your center uses conventional ventilation for infants at high risk of BPD. Alternatively, some centers will use high-frequency ventilation as the primary mode of ventilation for infants with a high-risk profile for developing BPD. At our center, we generally do this for infants at less than 24 weeks of gestation. With that summary, I'll open it up to questions. Thank you for your time and attention.
Thank you so much, Professor Jen. I just want to ask something about steroids. If you started, for example, hydrocortisone, there is a fixed course or a schedule for the dosing. You are starting with high dose, then decrease the dose, or how is the regime you are using for hydrocortisone for BPD?
So we do not use hydrocortisone for BPD routinely, and I think the evidence is mixed. So I don't have dosing recommendations for hydrocortisone for BPD. We do use a fair amount of hydrocortisone, usually in the setting of concerns for adrenal insufficiency, which often the population may overlap with those children affected by BPD. But when we are using steroids in our center for BPD, we use dexamethasone.
What is the course or the regimen dose you are using? For how long you will use?
So right now, we had a lot of variability in our practice because the evidence has been evolving and mixed. So often we use the DART protocol, which was a study that terminated early, dexamethasone tapered over 10 days, beginning with 0.05 milligrams per kilogram, I think is the starting dose. I hesitate to promote that particular dosing regimen or scheme because it was, a relatively small trial. It had to be terminated early. But that was, that's one approach we do is a 10-day tapering course aligned with the DART trial. There are other occasions where we actually will just do 3 days of dexamethasone. And usually during, we usually try on, day 2 to day 3 with getting the infants extubated when they're on the dexamethasone.
Okay. And no use for diuretics now?
No use of what?
You are not using any diuretics for BPD now? Spironolactone or?
Yeah. So in theory, I wish I could say that is true. I think we do not use diuretics routinely. I would say some of our most challenging infants with grade 3 PPD, the more severe form, there are some of those infants are on chronic diuretics. I think it's a little bit of becomes a bit of a cycle then because they often are then also on salt supplementation to keep their electrolytes in a normal range. And so, it almost defeats the purpose of giving the diuretic. So trying to find a balance. I'd say we don't routinely use it for kids with grade 1 and 2 BPD. There are a handful of kids with the kind of grade 3 BPD who are on chronic diuretics. But again, the response you see tends to, the chronic use, they tend to become less responsive to that diuretic.
Okay. There is a question saying, is there is a role for probiotics? It improves the BPD or has no role? The use of probiotics.
Probiotics?
Yeah.
I have not, there's been a lot of discussion in the US surrounding probiotics in relation to necrotising and enterocolitis. And you can see the relationship in terms of just, pro-inflammatory disease states. We do not use probiotics at our center. There is the NIH, I think, just convened another group to review the use. So a few years ago, the American Academy of Pediatrics came out with a statement opposing the use of probiotics, specifically in relation to necrotizing enterocolitis. But so they're not regulated by our Food and Drug Administration. And so there's been a number of cases where what is on the label for the contents of the probiotics doesn't match what is actually being administered, and case reports of neonatal sepsis. So I've not looked in a lot to the probiotics in relation to BPD, but I could appreciate, just with it also being a inflammatory disease state, that there could be some science there that needs more investigation.
Okay. There's another question. They are using only ventilatory support, nutrition, and sometimes the DART protocol. This is only what you are using for BPD?
So BPD is I wish it was a one cause, but because it's, so multifactorial, it really does take a multi-prong approach. So I think the other piece that, merits thinking about during this is just the baby's overall development. And the other kind of overlapping factor that sometimes comes up to manage early on is, pulmonary overcirculation for those infants who have hemodynamically significant PDAs. That remains, quite challenging and controversial in terms of how do we approach the PDA. We, in the absence of evidence that closure has improved outcomes, we do try to be selective in identifying those infants who are showing us systemic effects that can be, a worsening lung disease. I think that the challenge always for us is that, when you have fragile, sick lungs, there's always a question, do we wait too long? And do they have additional adverse effects from the overcirculation? But we just don't have great evidence to support early closure. So I think that is something that gets very much individualized for each infant, thinking about the cardiovascular management for those infants. And then as they get, approach that term-corrected age and beyond for those infants affected by BPD, we really critical to have the multidisciplinary management to think about just the overall infant neurodevelopment and environment, so that we are not only talking about an infant's lungs, but thinking about their awake alert time, what's kind of their physical environment, what kind of positive stimulation and input are they getting visually, tactilely, and kind of thinking about that whole baby aspect.
Okay. Last inquiry, what is the capacity of your unit in the neonatal ICU in my clinic?
Tell me that once more, please.
How many beds?
How many beds? So at Mayo Clinic, we have, it just increased. So we have the capacity for up to 39 infants in our level 4 unit, and an additional 24 infants in our level 3 unit. And so we're still getting used to our new bed numbers. We have a handful of beds that allow for maternal infant dyad care with a mom and baby co-located. So we're still getting used to how to count our bed numbers now.
Okay, thank you so much for your presentation
you.
and thank you for your time. Thank you. Okay, can you stop sharing now? Thank you. Now we will move to our next speaker. Our next speaker will be Dr. Manar An-Najjar. Dr. Manar is a consultant ophthalmology and he's subspecialized in the retina of the preterm infants. Dr. Manar will give us a talk about the latest update in ROP, retinopathy of prematurity, pathology, and management. Dr. Manar is a consultant in one of the biggest ophthalmology hospitals here, King Abdulaziz Ophthalmology Hospital. And he's one of the eminent ROP consultant in Riyadh. Thank you, Dr. Manar, and you can start.
Thank you, Dr. Nabil, and I am so honored to be with you today in this magnificent symposium, as usual. Today, I will talk about one of the classic topics in any pediatric or neonatology symposium is retinopathy of prematurity. So, yes. So we know, as everybody knows, it is a iatrogenic disease. It is not congenital, it's not hereditary, affecting the retinal vasculature of premature infants that usually weighted less than 1.5 kg or less than 32-week gestational age. Why this talk is important? Because we need to improve the awareness of neonatologists and pediatricians about the ROP, because in the latest few years, many studies was done about the awareness of pediatrician in many facilities. They found that almost between 15 to 60% of the assisted pediatricians believe that ROP is not preventable. And as we know, ROP is preventable. And almost about 45% of the assist participants did not know the proper time of ROP screening. So this leads us that the importance of more orientation and more awareness of our pediatricians, especially with the wide expansion of the NICU in our countries, and especially in the third world countries, without a proper care for premature babies in form of related to pediatricians, related to neonatology, and related to ophthalmologists. So this will lead us to the development, what is called a third epidemic of retinopathy of prematurity. So as we know, is ROP has jumped from the third most common cause of childhood blindness to the second leading cause of childhood blindness in the last few years. And is counted from economical and from a social point of view, that one blind child, it can be equal to more than 10 elderly disabled people. And usually in the 2020, almost estimated more than 13.4 million babies were born prematurely, less than 37 weeks, with the rates increase from 4 to 16%. And the ROP in this population also has increased from 16 to 56%. United States, the number still is stable. It's around 50,000 children blind worldwide from ROP, which the main majority of them in the Western countries. So this is diagram, or this is a map I like also to present. They are showing the distribution of different part of the, just a minute, yeah. Can you see a pointer? Yeah. Here, with what we can see here, the third world countries like in States and Canada and Western Europe, still we have almost every 100,000 live births, still we have severe blindness, almost between 10 to 45. Because of these, even if they are very developed countries, while what we can see in our countries, which they are third world, like in Saudi Arabia and like in Egypt, like in Middle East, mainly we have still the number is more than 45 blindness per 100,000 live premature births. This means that why? Because we are expanding, we have a lot of in ICU expanding in quantity without quality expansion, and this is leading to this increasing in numbers. So in Saudi Arabia, the incidence of ROP, according to papers just published recently, it ranges from up to 56% of screened premature babies. And severe ROP that needs treatments, it's up to 25% of all children and almost up to 10% of premature infant studies. Most significant independent risk factors in our country is a birth weight. We are not relying too much on the gestational age because usually we don't have a very strict and good antenatal system. So therefore, the most important and most reliable factor is the birth weight. The screening criteria that I have to mention today, which is not changeable a lot, it is the same if the baby born less than 1.5 kg or 32 weeks gestational age, or if it's more, we can put for screening if it's more than 0.1.5 or more than 32 weeks gestational age, if the babies have unstable medical conditions like blood transfusion, like respiratory distress, like hydrocephalus, like even if it's born more than this criteria, it should be seen because this is halts or stopped the development of retinal vasculature. So as we know, it is not a congenital, is a multifactorial disease, not fully well understood. And the most important risk factor, as everybody knows, is what's called as a prematurity. We have more than 50 separate risk factors have been identified, studied very thoroughly in the last years. But as we said, the most important in our country is the birth weight, gestational age, number of the days, oxygen administration, concentration of the oxygen. But the number of the days, it's more important than the concentration. The lower the gestational age and the birth weight is more serious to have a ROP. We have a new terminology called a micro premature infant when the baby is born less than 750 grams or less than 27 weeks gestational age at birth. It's found that the ROP incidence is almost 1 in 2, 50%. These babies would needs more frequent screening, needs more, almost 3/4 of these babies that develops ROP needs treatment. Except for the countries with a third epidemic of ROP, for example, low medical income countries that have widely expanded the numbers of an ICU without a quality expansion, serious ROP can be happen even in babies with a large gestational age and birth weight, which breaks the micro premature infant rules. Other risk factors, any systemic condition that interferes of the development and the maturity of the baby, like blood transfusion, intrauterine growth retardation, respiratory distress, hypercapnia, acidosis, sepsis, anemia, seizures. But there is a few recently very studied few risk factors that we have to put it in mind. And what I found it's most important nowadays is what's called the first of them. It's a postnatal weight gain. This is if the baby is not gaining 150 grams. This is a cut edge every 10 days after the 10 days of birth. This is usually associated with the high risk of ROP. Also, other important risk factor is the thrombocytopenia or the platelets low, less than 100,000, is associated also with a severe disease. Many studies was done in the literature, and they found that because the platelets, it's working as what's called a scaffold for vascular endothelial growth factors to wash these factors from the eye. When the platelet is low, the accumulation of these factors is increasing inside the eye, and this leads to development of the abnormal blood vessels and then hemorrhages and retinal detachments. Hydrocephalus also plays a great role in development or increasing the risk of the ROP, but the exact mechanism is unknown. Also, we have to put in mind outborn infants, those transferred from external institutions if they are delivered somewhere else and they came, for example, to our facilities. They need a high-level care, more frequent screening and treatment with laser or surgery or injections. We notice this in our hospital also. Always we are putting very strict attention to the babies that they are transferred from other institution, and this is not surprising. Most of them, sometimes they need intervention. Maternal risk factor, it's invariant factors. It's not that strict. It's many controversial studies like a multiple birth. Some studies show that if the maternal age was more than 30 years of age, almost associated with threefold increasing of the ROP. I don't believe this. Maternal diabetes is associated with almost 80% development of the ROP. Also, I didn't notice this too much, but antenatal steroids, they said that, or they claim that it protects against ROP. So we, from ophthalmological point of view, we have some factors that related to ophthalmology. For example, if the baby is born very prematurely and the lens is not fully mature and there is a blood vessels in the lens, I can see it with the indirect ophthalmoscope. This is called the tunica vasculosa lentis, and it can be associated with the severe and ROP. Also, I found in one interesting papers in 2021 that lighter fundus pigmentation is independently associated with the ROP, more aggressive and needs treatment. This paper also, we noticed this in our in ICU, that the babies who have a lighter, they have a more severe ROP, and sometimes it needs treatment. And this is also for the same mechanism. The pigmentary epithelial cells or melanin pigments is helping in washout of vascular endothelial growth factor in the eye. If they are missing or less, it can be lead to increasing of these factors and development of the severe ROP, especially in the ischemic phase. So classification is the same. There is no change, although the last third major revision for classification was done in 2021. We classifying ROP into zones. Zone 1, which is the most posterior one, what we can see here, it is, and then the zone 2, which is wider, and zone 3 is the temporal part. Usually, if the blood vessels are developing usually from the optic disc here in the center, and then it's extending to the zone 1, and then extending to the zone 2, and then to the zone 3. Usually, normally, what will happen it happens 4 weeks before term. It's reaching fully at 36 weeks of gestational nasally, because the nasal part of the retina is more closer to the optic disc than the temporal part, and the temporal is reaching usually fully vascularized at almost 42 to 44 weeks. So if they are failing to progression of these blood vessels at any zone, we'll name it the zone, and then we will define the stages into 5 stages, as we see here, into severity, and the clock hours is not important, this to mention for you. And then I will talk about what's called the plus disease. So zone 1, as you said, it's when the blood vessels stop, as we see in this image here, there is a blood vessel extending from the optic disc, extending to the periphery, and we see it's stopping here at the small line here. So this is called the zone 1, which it is measured by the radius extending from double the radius from the optic disc to the center of the this is called the macula or yellow spot. So the distance here is double. Anything before this circle is called the zone 1. So this is a very aggressive. When you have a patient with the ROP in zone 1, it means a more aggressive. If the blood vessel, it means less severity of the disease. This is zone 2 disease. As we said here, this is the radius, double the distance from the optic disc to the macula, reaching here. So it's the blood vessels already bypassing zone 1 into zone 2. So this is called a zone 2 retinopathy of prematurity. So what about the stages? Stages when the blood vessels, as we are seeing here, the blood vessels are extending and just reaching the blood vessels here and stopping here with no line, no ridge, nothing, just abrupt cessation of the blood vessel. This is called avascular or stage 0 or avascular retina. But sometimes when the line is developed and the endothelial cells here start to proliferate, as we can see, there is just a line. This is called the stage demarcation line. And this is, we can see here, this is called the stage 1. Okay, this is also in the retina. Stage 2, when the line is starting to occupying a volume, getting a ridge, becoming three-dimensional, and extending above the retina. This is called the stage 2 or the ridge. It means that the disease is a progression. Sometimes what will happen when this ridge is associated with the abnormal new blood vessels, which is called as a fibrovascular proliferation, that extending from the retina towards the vitreous, attaching to the vitreous here, this is called a stage 3 disease, and this is what's called as a red signal that we have to put it in mind that this patient may warrant treatment or injection or laser. So this is stage 3, as we see here. This is, we can see there is a ridge associated with the pink fibrovascular proliferation. We can see it also here. We can see this pink elevated fibrovascular proliferation. So this is a stage 3, which zone almost in posterior zone 2 or in zone 1. What will happen if this disease is progressed, it's not treated? What will happen? These elevated fibrous tissue, which is attached to the vitreous here, it's causing elevation of the retina, leading, as we say here, leading to what's called a partial or retinal detachments. And based on the location of the retinal detachment, based on the stages, it's total or subtotal, or if it is involving the center of the vision or not involving, we can classify them accordingly. So we can see here, for example, this is almost posterior zone 2. We can see extraretinal fibrovascular proliferation and slightly elevated. So this is called a retinal detachment, not involving the macula. So it is stage 4A. If it's, you see the retinal detachment extending towards the center of the vision, towards the disc, this is called a stage 4B. But if we don't treat these patients, this will extending to form a total retinal detachments. As we see here, all the retina will become folded like you are folding a piece of paper. And this is unfortunately nothing we can do at these stages. And this is with, if not treated or if it's missed, the patient will present, the eyes of the baby will be presented like a white membrane behind the lens, which is called as one of the differential diagnoses of leukocoria. So another definition that almost I've been asked a lot, it's what is the plus disease? Plus disease is getting more important in the latest revision. It is called congestion of the veins. As we can see here, the veins are become very congested and the arterioles are becoming very dilated, suggestive of direct communication, of direct anastomosis between or shunting between the veins and the arteriole, are suggestive of the severity of the disease. And the plus disease is one of the most important biomarkers that telling us that this baby will need treatment. If the presence of the plus disease, it means I have to treat this baby either with laser or injection. So this is a new revision in 2021. They defined a new zone, which is called, we know before it was the zone 1, zone 2, and zone 3. Now there is a new zone called the posterior zone 2, which is a 2 disc diameter almost surrounding zone 1. Also, there's a new definition, what's called the reactivation, especially in the era of the intravitreal injection. We know that intravitreal injection that we are giving was giving very commonly now in the treatment of ROP. Almost it's a temporary. So reactivation of the disease is usually very common with between 4 to 16 weeks post injections. And this is now they are the new definition of reactivation after treatment. We don't see this much in after laser. So according to the management, we need to manage these babies when we have a plus disease, when we have what's called as, according to the early treatment of retinopathy of prematurity studies that was published in almost around 2005, we defined this into 2 categories, high-risk categories. If the baby has a zone 1 disease with a plus disease, or if have a stage 3 in zone 1 without a plus disease, or stage 2 or 3 in zone 2 with a plus disease. So what we're noticing here, high risk that warrant treatment is always if there is a plus disease, except if the disease is in the zone 1 here, which showing extensive fibrovascular proliferation, but no plus disease. Okay, so this we have to treat them within 72 hours by arranging either injection or laser, as we will talk later. So the ROP can progress to blindness during the first 3 months of the life. We have to use the treatment window of opportunity. So what's calling it's ROP screening is misnomer. It's not a screening. It's very detailed. Examination should be done by the detailed professionals, because when we have to catch the disease early and we have to treat early, we can prevent blindness. So therefore, as in one study here in UK, we need to do from 40 to 55 examinations to detect a single case requiring treatment. Not one baby, but you mean different babies. So we have to be very meticulous in our examination and there is no allowance of false negatives or imperfection, because if you miss this baby, the baby will get blind. So the target population is the same as we said in the screening, as we discussed before. When we initiate the screening, we said initiate the screening. There is a many tables. It's not advanced too much, but what was it easy for everybody that either postmenstrual age is 32 weeks, not 31, it's 32 weeks, or 4 weeks after birth. Which one is not earlier, but which one is later? For example, if the baby born at 27 weeks, okay, so at 4 weeks it will be 31 weeks or it's 32. So I will first screening visit, it will be at 32 weeks, especially but in some certain situation when the neonatologist or pediatricians, he want me to examine the baby earlier. For example, if there's no problem to do it. But according to the many tables and the criteria, postmenstrual age 32 weeks or 4 weeks after birth, which one is later? Usually using neonatal ICU, just anesthesia, speculum, antisepsis, warm, dry, fully antiseptic conditions. Neonatology nurse or doctor should be around because it's very also invasive. It's sometimes painful, and we have to be very careful about the monitoring the vital signs during the examinations. One very important paper, as I discussed before, which is validated in many Western countries, in Canada and in States, regarding what's called the GROP study, growth ROP study. They found that they want, the ROP examination is not easy, not available, all the professional doctors, ophthalmologists, not available all the time. So they want to reduce the number of the babies, premature baby that needs to be evaluated for ROP. Therefore, they validated some what's called a growth ROP. The ROP examination of high-risk babies is mainly related to the rate of growth postnatally, as we said before, that if the baby is born, for example, less than 28 weeks, these have to be screened. If the birth weight is less than 1 kg, they have to be screened. If the weight gain is less than, let's say simply at less than 150 grams every 10 days, we have to screen, or if there is a hydrocephalus. They found that this is a screening protocol, this algorithm, if we'll do it, this is the sensitivity to detect and catch the ROP that needs treatment is 100%, and reducing the risk, and reducing the number of ROP screening sessions by 30%. And in Western country, the money is very important. So this is a great success for them. And it's always now it's validated in many centers. Even in Sweden and in Denmark, I think also it's validated. We have to do our studies to see if this works in our population or not. So we end the screening as if the retina is fully vascularized, or if the postmenstrual age, the baby is 45 weeks, only if the patient or the baby, he never received injections. But if he will treat it with anti-VEGF, usually we need to follow up until 65 weeks gestational age. And many of these patients, we need to do laser at the end. So this is the main issue. This is the new changes in the finishing or ending the screening. If the babies have no ROP, we can follow until 45 weeks of age. And if the patients, have no previous anti-VEGF given to 45 weeks, if anti-VEGF was given, we have to follow until 65 weeks. So let's talk about the treatment. As we said about the laser is the mainstay of management. Laser photocoagulation is a mainstay of management. What is the indication? Because sometimes we are choosing some baby to do laser. Sometimes we are using babies to give injections. I have been asked many questions about why this and why that. So this is, I'm trying to summarize about the indication, contraindications, and advantages and disadvantages. Laser photocoagulation is the mainstay of management. Usually we are using nowadays in mid to anterior zone 2 active ROP disease. and if there is a reactivation of the ROP post previous injection. So I have to go for laser. If the patient disease progressed to stage 4A, we can go for scleral buckling by doing a band around the eye. And if it's stage 4B or 5, if the macula is involved into or total detachment, go for vitrectomy. Nobody is doing it unfortunately, in our countries because of the guarded prognosis and the result is very non-promising. The other now new modality that's widely used is intravitreal injection, either Avastin, Lucentis, or Eylea. They are different. We are usually indicated for zone 1 according to the many studies like beat ROP and posterior zone 2 active ROP. So mid zone 2, anterior zone 2, we are going for laser mainstay, but if for zone 1 and the posterior zone 2, we have to go for injections. Why? We'll talk about it later. So what is advantages of laser photocoagulation? It's one and done. One session and done. If done properly, success rate is very high. In our institution is over 95% of the patient. It will regress for life. And we have finite follow-ups. We will not follow up these babies definitely for 2 to 3 months post-laser and done. But it has some long-term effect, good long-term effect that prevent later on retinal detachment. So it has advantages. This is the advantages of using the laser. Disadvantages, laser therapy is not easy to learn, needs highly skilled retinal professional, which is not always available. Irreversible structural damage, as you said here, we are burning the peripheral retina. So we are damaging the peripheral retina, so irreversible structural damage. So especially if we are doing it sometimes in severe cases in mid-zone or anterior or posterior zone 2, we can ablate almost 2/3 of the retina. It ends with the restriction of peripheral visual field, inflammation. It can be associated with some ischemia in the anterior segment, cataract. It can be happens as a consequences of laser. And the other most serious long-term disadvantages, the babies post-laser usually associated with a severe myopia ranges more than 7 up to 15 diopters compared to intravitreal injection, and needs to be followed yearly with a pediatric ophthalmologist to give a glasses. Also high risk to develop strabismus and anisometropia and amblyopia. This is one of the major disadvantage, long-term disadvantage of using the laser. So intravitreal injection, we have Avastin studied by Beat ROP study in 2008, Rainbow study 2016, and Butterfly for Eylea in 2019. All they have the same effect. But also we have a lot of limitation about these. We are giving TKDS materials, half adult dose, giving inside the eye under full aseptic condition, almost small eye, 1 millimeter from the limbus, and the advantages for intravitreal injection, that it's easy to use, anybody can do it, done at the bedside, just for 5 minutes, often without need of the intubation. Rapid response, usually immediately or next day, comparing to the laser, which needs almost 1 week. Better visual field for later onset. There is no damaging to the peripheral retina. Visual acuity is improving later on in life. There is no high myopia as in comparing to the laser. But it's not coming without disadvantages. It's a delayed vascularization. When you are giving intravitreal injection, it is totally changing the behavior of the retinopathy of prematurity and vascularity of the retina. Also, one important issue here is a temporary effect, recurrence and reactivation. It is very common from 4 to 16 weeks. Usually 20% of these babies have a recurrent disease. If you're not catching it, if the patient lost follow-up, it will progress and he becoming blind. And this is one of the serious issues that we have to put it in mind. Challenging follow-up, they need infinite follow-ups until it's vascularization, because the injection is delayed, the vascularization of the retina. A long-term effect about the anti-VEGF itself in the systemic and neurological development, we don't know yet. These we are starting using almost 5 or 6 years ago. Uncertainty about the drug dose. We need a large multi randomized controlled trials, say the exact dosage, the exact of the drug, and how much in systemic circulation. They found, for example, in Avastin, they found traces after 3 weeks of giving intravitreal injection of intravitreal avastin in the systemic circulation. How is the effect on neurological development? We don't know, because long-term studies, we don't know is this is because of the delayed development or because of the injection. Other risk, because it's technically, sometimes when you are giving injection inside the eye, it ended with, sometimes you will implant a bug inside the eye, ending with endophthalmitis or infection of the internal layers of the eye, or sometimes because the lens is very large, it ends with injury of the lens. So it is not, it's a temporary procedure. We are using it in some stages to avoid ablating large retinal areas. Now they have what's called as a RITCAM telemedicine. We have two programs in Saudi Arabia. One is sponsored by Ministry of Health, and the other are sponsored by King Khalid Eye Specialist Hospitals. Many centers, they have what's called a RITCAM. It's a camera done by neonatologists or pediatricians or by even a nurse, just putting anesthesia, dilating the pupil, and taking an image, sending to the server, reading the servers, and then sending a doctor if the patient needs a warrant treatment or laser or injections. So this is, we hope that this will become more progressive and reducing the rate of blindness from the ROP. So in the end of what is the takeaway message? No infant allowed to fall between the cracks. Every baby should be eligible infant should be referred. Appropriate referral is responsibility of the nursery. No give killer. Don't open ICU if you don't have a professional and good ophthalmologist. We have to also do proper documentation of the ROP. Parents should be counseled pre-injection, pre-laser, post-injection, post-laser, post-discharge to know exactly what we are dealing with this disease. Future direction, there's not too much. Some people that are working on genetics, nothing happens. Stem cells also is not working. Changing the metabolism of developing retina, trying to alter the pathophysiology of the ROP, but no further studies or only trials. Thank you for attention and for presence. I'm ready for any questions.
Thank you so much, Dr. Manar, for your very updated lecture. I just wanted to ask about the maternal risk factors is the IBM baby.
Sorry, Dr. Nabil.
Hello?
Yeah. Yes. I can hear.
Diabetes of the mother is one of the maternal risk or no?
The maternal diabetes, right?
Yes.
Yeah, I honestly,
one of the risk factors?
Yes, it is unvariant factor, independent factors. I found almost 3 or 2 papers related to the ROP. So I'm told I don't believe in this. Practically, they are saying that 3 times more risk to develop ROP their babies comparing to premature to the other normals. But unfortunately, as I said, and I don't believe, I see a lot of, in my career, I see a lot of premature babies with the maternal diabetes. I didn't feel that they are more risk. What I feel it's more risk these days, by my practice, it is the hydrocephalus, thrombocytopenia, and postnatal growth rate. This is the most important. But
Okay.
And I don't believe this, yes.
So you don't recommend to screen the full-term baby IBM?
Exactly. No, I don't. I don't screen.
Okay.
Yeah, I don't screen this baby. Full term, don't screen unless you want to screen for something else. But for ROP, unless they are premature, according or borderline prematurity, I will take a benefit of doubt. I will screen them.
Okay. There's one question. If the baby is 31 weeks, when to do screen?
If the baby what?
31. Preterm, 31 weeks.
Yeah, 31 weeks. When he was born. At
31
which
weeks.
He born 31 weeks.
Yes.
So yeah. So in this cases, in this, if he born at 31 weeks, I will see him at 34, 35 weeks.
Okay. So after 4 weeks. 4 weeks
yes.
from delivery.
Yes, because we need it is a process. It has to go. There's a process. We cannot have ROP immediately after birth or within weeks. We have 2 stages. We have what's called as a hyperoxic stage, which is usually extending from 28 to 32 weeks, and then ischemic stage, which is extending from 32 to 36. Mean ROP is always about 36.9. Main active ROP needs treatment at 37 weeks because we have to put those stages. Yes.
Okay. Thank you so much, Dr. Manar, for your excellent presentation. Just wait a minute. There's someone. Why the mother received steroid that decrease the ROP?
Honestly, I don't know. This is just one of the papers, just they saying that antenatal steroid according to the trials and no explanation for that. This is because the antenatal steroid can helping the, for example, helping the good, for example, like a surfactant, like any other issues that
Yes,
helping.
actually, steroid for the mother is helping to resolve many of the diseases, but it is unknown mechanism.
Yeah, helping the
Okay.
general condition of the baby. Yes, I
Yes.
agree with you. Yes,
Yes. Thank you so much for your nice presentation and for being with us.
thank you.
Thank you.
Thank you.
So you can stop sharing. Our next speaker will be Dr. Muhammad Adel. Dr. Muhammad Adel is a professor of gynecology in Shams University. And he is a consultant and department of the OB/GYN department in Riyadh Hospital, Saudi German Hospital. He will give us a talk about the role of obstetrician in improving neonatal outcome. Thank you, Dr. Muhammad Adel, for being with us, and you can start to share.
السلام عليكم ورحمة الله. I'm Dr. Muhammad Adel, professor of OB/GYN at Shams University and consultant of OB/GYN Saudi German Hospital, Riyadh. Today I will be talking about the role of the obstetrician in improving the neonatal outcome. First of all, I would like to share some statistics with you. At first, what is meant by the neonatal period? Neonatal period, it is a golden period. It's considered the first 28 days of life, which is the most critical and vulnerable time for the child survival. About 2.3 million newborn deaths was recorded in 2022. The neonatal period accounts for the greatest risk of the childhood mortality. About 60% of under age of 5 years child deaths was found, and nearly 2/3 of all are infant death. Infants is from birth to 12 months. يعني about 2/3 of the infant mortality occur in the first year, and in 2022 there was recorded 2.3 million deaths in the first 28 days of life. Typically, 98% of the neonatal deaths occur in the developing countries, with the highest rates in South Asia. In this region alone, an estimate about 2 million children die within a year of birth. And the neonatal mortality rate is 51 neonatal deaths per 1,000 live birth in South Asia alone, as compared with 10 per 1,000 in Europe and North America. This is a flow chart where in 2022, about 47% of all deaths in children under the age of 5 years occurred in the neonatal period. As we said before, the first 28 days of life. This is among the most vulnerable periods of life and requires intensified quality intrapartum and newborn care to address this significant challenge. As we talk about the risk factors of the neonatal morbidity and mortality, we can talk about the unsupervised deliveries, which is the most neonatal deaths occur at home following unsupervised deliveries, making it difficult to accurately identify the causes, lack of medical supervision during childbirth, and a significant risk factor for neonatal morbidity and mortality. The second risk factor is the premature birth. Premature birth remains one of the leading causes of neonatal death. Babies born prematurely are at a high risk of complications such as respiratory distress, infections, and developmental issues, which can be life-threatening if not properly managed. Birth complications also is considered one of the most important risk factors of neonatal morbidity and mortality. Like birth asphyxia and birth trauma are major contributors to the neonatal morbidity and mortality. Complications during labor and delivery can deprive the infant of oxygen, leading to brain damage, organ failure, and even death if not promptly addressed. Now about the main topic, how is the obstetrician rule is very important in improving the neonatal outcome. Here, the obstetrician rule, it has four main stays: the preconceptional care, which is very important, antenatal care, intrapartum care, and finally, it's very important to do a postnatal collaboration where post-delivery, the obstetrician must work closely with a highly qualified neonatologist to provide a comprehensive care for the newborn, addressing any immediate or long-term needs and supporting the transition to the extrauterine life. Because this is a very important zone where the transition from the intrauterine life to the extrauterine life, very important. I'm here as well.
صوت الدكتور محمد واضح يا دكتور أستاذ علاء؟
نعم نعم يا شيخ، واضح دكتور نبيل. واضح للجميع.
واضح دكتور محمد، واضح.
طيب كمل. في الكلام كده.
So as we're talking that there is very important postnatal collaboration, which is very important in collaboration to work between the obstetrician and the neonatologist for the important transitional zone between the intrauterine life and the extrauterine life, which needs long-term needs and support for this transitional zone. If we talk first about the importance of the preconceptional care, the preconceptional care is very important as it gives an idea about the preventive health care, individualized guidance. Then we have to do a comprehensive education. The preventive health care, the preconceptional care should be an integral part of the primary and the preventive health care for all women of the childbearing potential. This proactive approach helps identify and address potential health issues before pregnancy, optimizing the mother well-being and reducing the risks to the developing fetus. The individualized guidance, preconceptional care provides an opportunity for healthcare providers to work closely with women, assessing their unique medical history, lifestyle factors, and family planning goals. This allows for personalized recommendations to improve maternal and the fetal outcomes. Finally, the comprehensive education. During the preconceptional care, healthcare providers can educate women on important topics such as folic acid supplementation, managing the chronic conditions, avoiding teratogenic exposure, and adopting healthy behaviors. This empowers women to make informed decisions before and during pregnancy. How to cause and assessment factors for the preconceptional cares. First of all, we have to take a medical history evaluation, assessing the individual's medical history, including any chronic condition in the previous pregnancies, family and medical history. This helps to identify potential risk and guide personalized interventions. Second of all, we have to share the lifestyle factors, evaluate the individual's diet, exercise, habits, substance use, and exposure to the environmental hazards. These lifestyle factors can significantly impact the fertility and the fetal development. Then we have to do a genetic screening. We have to conduct a genetic testing to identify any inherited conditions or genetic predisposition that may affect the pregnancy or the child health. This allows for the proactive management strategies. Vaccination history, review the individual's vaccination status and provide any necessary immunization to protect against infectious disease that could harm the fetus during the pregnancy. If we go in the detailed assessment of the preconceptional care, The maternal age is very important risk for infertility and the fetal aneuploidy, miscarriages, gestational diabetes, preeclampsia, and the stillbirth. Individuals should be aware of these risks and the consequences of delaying conception until their 30s or 40s, and consider this is a reproductive health plans. Also, we have to check for the medical history of the mother. So we have to take a thorough medical history is a good starting point for discussing how pregnancy can affect maternal health and the effect of the maternal health and behavior of the fetus and pregnancy. This include identifying any chronic medical condition, past surgical procedures that could impact the pregnancy and although impacting the neonatal life. Also, we have to check for the teratogenic medications. A key component is to identify any use of any teratogenic component which may lead to teratogenicity in the fetus. For an example, the warfarin. We should stop the warfarin and replace it with low molecular weight heparin, especially in the first trimester, or also other drugs like extended release nifedipine, which is important to replace the lisinopril, which is teratogenic in the first 3 months of life, of the intrauterine life. Also, we have to, in the preconceptional assessment, should be considered several additional factors that can impact maternal and neonatal outcomes, like the reproductive history, which is very crucial, and the past gynecological and the obstetric history. Genetic risk factors and family history are similarly important, as certain heritable conditions or other risk factors can be impacting the offspring. Substance use, we have to check for the substance use like nicotine, alcohol, opioids, and non-prescribed medication should be thoroughly screened with the mother before getting to conception. Infectious disease and vaccination history also must be assessed because some other infectious disease like cytomegalovirus, Zika virus, and Chagas disease can cause teratogenic risk factors during pregnancy. After we take the through history, we have to do an assessment and physical examination for the mother. All the females going into the preconceptional age, we have to do physical examination, including the assessment of the heart, the breast, the lungs, the thyroid, abdomen, mouth, and the genital tract. Also, the body mass index should be assessed. This examination is a pragmatic approach to detect the most common condition that can affect maternal health and pregnancy outcome. Also testing for the HIV, the rubella, IgG, diabetes, and other, we have to do like CBC, screening for TB, TSH, and we have to check for the up-to-date vaccination. And as regarding the diabetes, the American Diabetes Association recommends that we have to go for euglycemia and to the hemoglobin A1C to be less than 6.5%. When the hemoglobin A1C is less than 6.5%, this reduces the risk of congenital anomalies, miscarriages, preeclampsia, macrosomia, preterm birth, and other complications. Also, the maternal condition should be assessed, like hypertension. It should be controlled prior to the conception, control of the bronchial asthma, if any thyroid disease, epilepsy with revision of the medication. For an example, valproate should be discontinued and give adequate supplementation of folic acid 3 months prior to the conception to prevent the neural tube defects. Patient taking oral anticoagulation should be discontinued and exchanged to the low molecular weight heparin. Also, patient with well-known heritable disease, these patients should be directed to a specialist in genetics, which is usually warranted to discuss the result of the screening test and the risk of the disease in the fetus and the natural course of the disease to decrease the incidence of the heritable disease. So to summarize the measures of the successful preconceptional care, we have to absence of tobacco use, absence of sexually transmitted infection, teratogenic avoidance, healthy weight, so that the body mass index should be between 18 and 30 kilogram per meter square surface area, giving folic acid, especially 3 months before the conception, optimize the glucose management, planned pregnancy, and the first perinatal visits should be before 12 weeks of gestation. Second of all, we have to talk about the antenatal care. Here, the patient is pregnant. So the 3 main components of the prenatal care are the risk assessment, the health promotion and education, and the therapeutic intervention. The major core of the antenatal care is to help to ensure the birth of healthy newborn while minimizing maternal risk. There are several components involving and achieving this objective. Like we have to do early and accurate estimation of the gestational age, which is very important and cause protection against prematurity, identification of pregnancies at increased risk for maternal, fetal, or subsequent neonatal morbidity and mortality, ongoing evaluation of maternal and the fetal health states. Good history and the examination. Calculating the estimated date of delivery from the first day of the last menstrual period is very important and crucial for managing the pregnancy, especially with regard to the timing, interventions, and monitoring of the fetal growth. Ultrasound examination in the first trimester is very important for the determination of the gestational age, particularly is very important. First trimesteric ultrasound can lead to early detection of multiple gestation and determination of chorionicity and amnionicity for the twinning, as like cases of monochorionic, monoamniotic twin, and its bad impact on the life of the neonatal life. We have to do the aneuploidy screening and the diagnosis. We believe that all pregnant patients should be offered prenatal genetic screening, like the serum biomarkers screening with or without nuchal translucency, and doing cell-free DNA screening, and should have the option of having an invasive procedure for diagnostic testing instead of the non-invasive screening, like the chorionic villus sampling or the amniocentesis. Fetal anomaly screening, increasingly a first trimester fetus anomaly screening is performed in conjunction with or without first trimester aneuploidy screening. So we have to do the aneuploidy screening, either the non-invasive testing like the cell-free DNA or the invasive testing for the detection of any abnormalities like chorionic villus sampling or the amniocentesis. Also, sometimes we have to do the fetal anomaly screening by the first trimesteric ultrasound, which is done in conjunction with or without the aneuploidy screening. Here the same again, if a mother skipped the antenatal assessment for the diseases like hypertension, asthma, or thyroid, or epilepsy screening, we have to do it again during the antenatal care period. The hypertension should be controlled, diabetes should be controlled, thyroid diseases, epilepsy should be controlled, shifting of the drugs which are teratogenic like the valproate into more safer drugs, starting folic acid, and all the heritable condition again should be addressed to the genetic specialist. In the antenatal care testing, we have to do the laboratory testing like the standard panel we said before, like CBC, blood sugar, hemoglobin A1C, etc. We have to check for the ABO and the RhD type and antibody screening for the Rh negative females to be given an anti-D course between the 28 and 34 weeks and to be given post-delivery. We have to do a urine culture. Routine urine culture is very important in early pregnancy because untreated asymptomatic bacteriuria places the patient at high risk of developing pyelonephritis and increased risk of preterm birth. Screening for the GDM between 24 and 28 weeks for the detection of gestational diabetes and the bad impact of gestational diabetes if uncontrolled. Patient of pre-gestational diabetes and type 2 diabetes should have a good control and euglycemia with good control of hemoglobin A1C, as we said before, to be below 6.5 to decrease the risk of congenital anomalies. We have to screen for the sexually transmitted diseases like HIV, syphilis, and herpes simplex virus. Also, we have to screen for the group B hemolytic streptococcus because with the bad impact of group B hemolytic streptococcus on the fetus later on. Then, during the antenatal care, what to do as a management inside the intrauterine life. One of the very important managements that is done during the intrauterine life is antenatal corticosteroids. Administration of antenatal corticosteroids to the woman who is at risk of imminent preterm birth is strongly associated with decreased neonatal morbidity and mortality. Neonates whose mother receive antenatal corticosteroids have significantly lower severity, frequency, or both of the respiratory distress syndrome. So how we use the antenatal corticosteroids? We have to give a single course of corticosteroids is recommended for the pregnant woman between 24 weeks of gestation and 34 weeks of gestation for those females who are at risk of premature delivery within 7 days. It also may be considered for pregnant women starting from 23 weeks of gestation who are at risk of preterm delivery within 7 days. It's better to give a single dose of betamethasone between 34 and 37 weeks who are at increased risk of preterm birth within 7 days and who have not received a previous course of antenatal corticosteroids. Number 2 is antenatal antibiotics. As we know that we have a prophylactic antibiotic regimen in the patient with a preterm premature rupture of membranes. The goal of the antibiotic therapy is to reduce the frequency of maternal and the fetal infection and thereby delay the onset of the preterm labor and protect against chorioamnionitis and the bad impacts of the preterm premature rupture of membranes. طيب, the drug regimen, we administer a 7-day course of prophylactic antibiotics to all patients with preterm premature rupture of membrane before 34 weeks of gestation who are managed expectantly. There is some variation in the regimen. Our preferred regimen is to give azithromycin 1 gram orally upon admission, then ampicillin 2 grams intravenously every 6 hours for 48 hours, followed by amoxicillin 750 milligrams orally every 12 hours or 500 milligrams every 8 hours for additional 5 days. This will be protective against the preterm labor and the chorioamnionitis. Chorioamnionitis is associated with a 2 to 3-fold increased risk of adverse perinatal outcome. So if chorioamnionitis, the complication, it can lead to the neonatal sepsis, septic shock, respiratory distress syndrome, intraventricular hemorrhage, cerebral white matter damage, necrotizing enterocolitis. In case if we happen chorioamnionitis, how should we treat chorioamnionitis? Now, patient, if it's going into normal vaginal delivery, we give 2 gram ampicillin IV every 6 hours, then gentamicin 5 milligram per kg once. Or if at cesarean birth, we add at the same regimen metronidazole 500 milligram IV or clindamycin 900 milligram IV every 8 hours. If we want to check about the group B streptococcal, who are subjected to give the screening for the group B streptococcal and to give the IV antibiotics. For those who have positive screening culture for the GBS, either vaginally or rectally, those who have positive history of birth of infants with early onset GBS, or they have GBS bacteriuria during the current pregnancy, unknown antepartum culture status. Now, if there is intrapartum fever more than 38 degrees Celsius, preterm labor below 37 weeks of gestation, preterm premature rupture of membranes, prolonged rupture of membranes more than 8 hours, or if there is positive intrapartum nucleic acid amplification testing. What should we do? We should give intrapartum prophylaxis to protect against the neonatal group B streptococcal infection. How can we give? The routine regimen is to give penicillin G 5 million units intravenously initial dose, then 2.5 million units to 3 million units intravenously every 4 hours until the delivery. In cases of penicillin allergy or if penicillin is not present, we give cefazolin 2 grams intravenously as an initial dose, then 1 gram every 8 hours until the delivery. The role of antenatal magnesium sulfate, we have many rules for antenatal magnesium sulfate. Magnesium sulfate is important. Researchers indicate that it can increase the risk of periventricular leukomalacia. A systemic review suggested that this drug can play an important role in the prevention of the cerebral palsy, provide direct neuroprotective approach and neuroprotective effect to the baby's brain in those in less than 34 weeks. The dose of the magnesium sulfate, our preferred dose is to give magnesium sulfate 4 grams intravenously over 20 minutes, followed by a maintenance dose of 1 gram per hour for 24 hours. Care of the newborn during delivery. It's very important to care for the newborn during the delivery by the continuous intrapartum fetal heart rate monitoring, because the changes in the fetal heart rate is associated with fetal oxygenation, such as the baseline heart rate, frequent deceleration, and or absence of fetal variability can affect the oxygenation of the brain and can result into the hypoxic brain injury or death. Prevention of birth trauma and injuries is the final step. How to protect the most important protective factors against the best management is to protect against the risk factors. Like what? The risk factors is like operative vaginal deliveries, obstructed labor, abnormal presentations, preterm deliveries, and the maternal obesity. Types of birth injuries is injuries to the soft tissues and the skin, lacerations, head injuries, nerve injuries, or the injuries to the limb and abdomen. In this case, we have to predict the risk factors and guard against these risk factors to decrease the injury and the birth trauma. And if one of the risk factors is present, deliveries should be attended by a highly qualified neonatologist. So as to summarize, the group pre-conceptional care, antenatal care, and intrapartum care is very beneficial in improving neonatal outcomes to decrease the neonatal mortality rate. Delivery should be attended by a highly qualified neonatologist for the best fetal outcome. Thank you.
افصل عندك بقى الصوت ميوت. Thank you so much, Dr. Muhammad, for your excellent presentation. صوتي مسموع كده يا أستاذ علاء؟
تمام دكتور، تمام، تفضل.
تمام. Okay, so our next speaker will be Dr. Omar Al-Harbi. Dr. Omar is a consultant pediatric infectious disease in Imam Abdurrahman Al Faisal Hospital in Riyadh, KSA. He is the head of the Antimicrobial Stewardship Committee. Dr. Omar will give us a lecture about the musculoskeletal infections and update. Thank you, Dr. Omar, for being with us, and you can start share your presentation.
Thank you so much, Dr. Nabil, for having me in this symposium. I'm really honored to be here. My talk today, it will be an update about a common topic, and I will try to summarize it and make it to the point. Musculoskeletal infection, mostly I will talk about acute osteomyelitis and bacterial arthritis. So in my review, I will aim to review the recent update and guidelines in the literature regarding the clinical approach, diagnosis, and the treatment of common pediatric musculoskeletal infection. As we know, it is challenging to diagnose due to their vague and non-specific clinical presentation. Usually, the delay it may lead to delay in the diagnosis or treatment. It may lead to chronic disability or even fatal outcomes. So the pathogenesis in pediatric usually depends on two main components, which is the occult bacteremia and also the susceptibility on the well-vascularized metaphyses, and it will lead to invasion of the bacteria to the bone matrix. Almost 15 to 50% of the infection, it will involve both the joint and the bone. And those combined infection, it may lead to higher level of inflammatory markers and also more sequelae and longer treatment courses. So as we see here in the MRI, this is for a child who have in the black arrow, there is a joint effusion, and also there is an abscess in the muscle. Also in the second picture for the same child, the abscess is invading the bone cortex for the proximal femur. So in microbiology, the most common organism, it is the Staph aureus, and also it is methicillin sensitive or methicillin resistant, and it has been most commonly isolated in cultures in the past 4 decades. Before the vaccination, the Haemophilus influenza type B was the most common organism. And after that, Kingella kingi became a prominent isolated organism, especially in children less than 4 years of age. It is a gram-negative bacterium in the oral mucosa, and it is a fastidious organism that requires not only cultures, also molecular based diagnosis. So in this picture, only depending on the culture alone, the Staph aureus, it is the most common. It is 44%, followed by the beta-hemolytic streptococci and Kingella kingi. With the combined culture and as well the molecular testing, the Kingella kingi represent 53% of the most common infections. So the prevalence, it is almost 8 in 100,000 in children per year, with the highest prevalence in the children less than 5 years of age. It is more common in male due to their physical activity, and which predispose them to repeated microtrauma. The most commonly involved bone and joint, it is the long bones, including and the joints, including the hips, knees, and ankles. And as we see here, the hips represent almost 27 to 30% of joint infection, as long with the knees 25 to 40%, ankles only 23%. Lower leg, long bones, fibula and tibia almost represent 35%, and femur represent 24 to 27%. So the diagnosis, it depends on the history. One of the prominent symptoms that present for children, it is fever and also inability to use the affected extremities, and also involves the major weight-bearing joints and long bones. And 20% of children, they reported usually having a history of fall and a few days to weeks prior to presentation. And usually it is ignored by the parents due to the recurrent or repeated falls and injuries in this age group. Also, there is a few points needed to be focused on in the history, including the animal exposure. We have seen now many families that they have pets at home, especially cats. Also, it also includes reptiles with the turtles, the most prominent animal that they have at home. And this will guide us regarding the most common pathogen. Also, history of ingestion from milk ingestion, brucellosis, it is a prominent as well organism that needed to be excluded. Also, the history of immunization is important. The history of prior disease or recent pharyngitis as well, it is important, and recent illness, either diarrhea or upper respiratory tract, it is important to exclude in the history. In physical examination, usually it differs from child to child. Some children will present with simple and they are well appearing with mild only local tenderness, but some of the children, they will have an overwhelming sepsis. So usually in uncomplicated acute hematogenous osteomyelitis, they will have pinpoint tenderness and mostly at the metaphyseal site. And it is combined with warmth and swelling. What could affect the physical examination? The degree of pain and swelling and tenderness. It depends on the duration of symptoms before presentation for medical evaluation, the location of the infection, and also the age of the child along with the pathogen. So the more resistant pathogen, the more severe presentation. So for laboratory testing, we recommend initially to start with the complete blood count, including differential inflammatory markers, ESR, and the blood culture should be obtained prior to starting antibiotics. Usually blood culture in some children, in some studies showed to have presence of pathogen of almost 60% in their patients. So for laboratory testing, do we need additional lab testing? Yes, sometimes with the history, it will guide us. If there is a history of milk ingestion, we need the serological testing such as Brucella titers. Also, if there is a history of contact with sick patient or a TB patient, we need to do the tuberculin skin test or interferon gamma release assay. And it may be useful depending on their clinical scenario. So if the patient went to surgical intervention, the surgical specimen should be, after obtaining, should be undergone for bacterial, fungal, and mycobacterial cultures. And as well, the joint fluid or aspirate, we should include also, should be put in blood culture to accelerate the identification of the organism. So for radiological evaluation, it is a crucial component for the diagnosis, and usually we start with the simple, plain, conventional radiograph. It is helpful to exclude other, it is widely available, and it helps us to exclude other diseases such as if the child has a fracture or any simple usually it will take time to show the osteomyelitis or maybe showing us some soft tissue swelling, but usually it is help us to exclude other pathologies. So ultrasound, it is fast, non-invasive, and also it helps us to be as therapeutic and diagnostic. Therapeutic with the ultrasound guided intervention, we can take samples of the synovial fluid and send it for microbiology, and also diagnostic to assess the severity of the joint effusion. MRI, it is considered superior. It is the most specific and sensitive, and it is the gold standard to diagnose the site of the infection. And also it helps us to see the osteomyelitis simple or it is complicated by other pathologies. So for surgical intervention, there is 3 basic reasons, which is the most important reasons. First, it is the microbiological diagnosis. It will help us and guide us regarding the antibiotic therapy. So it is also important as a source and control because this is the most step in treatment. If the patient didn't have proper source control, he will continue to have symptoms and a longer duration of therapy with antimicrobial. So it is important for us after assessment of the patient, if he has any necessity for the surgery, needed to be done as soon as possible. So also it will help us to preserve the maximal function, and it would increase the chance of complications such as a vascular necrosis or permanent cartilage damage. So the treatment, usually the antibiotic selection and adjustment depends on the culture and sensitivity usually, but sometimes it's really difficult because the initiation of therapy and then the intervention, this makes it up to 50% of the cases it will yield negative culture. And the treatment current practice, it is usually 3 to 6 weeks, depending on the age and the disease severity. So currently the literature recommending or suggesting that the early transition to oral therapy and to make it as short as possible, especially in simple infection, not complicated and the sites other than the vertebra. So for complicated form, such as multiple distribution in immune-compromised children with children with the foreign body or extensive bone destruction, usually the transition it will be delayed, and sometimes some children will have up to 14 days of IV antibiotics, and sometimes even longer, 21 days in children less than 3 months of age. So what's new in this era? The last year, the Infectious Disease Society of America, they published 2 guidelines. The first guidelines about acute bacterial arthritis and acute hematogenous osteomyelitis in pediatric. I will take in summary regarding their new recommendations for non-invasive diagnostic laboratory testing. They recommended that blood culture and should be obtained prior starting the administration of antimicrobial therapy. Also, measuring serum CRP or C-reactive protein at the initial assessment, it will help us to guide us. It will help us to guide us regarding the antimicrobial therapy, and also to show us the clinical response for the patient. For some patients, regarding the procalcitonin, it is based on patient by patient, case by case, because if the patient is clinically well appearing at the presentation, there is no need to do the procalcitonin. This is why they suggested against it. But the patient presented with severe overwhelming sepsis, they recommend to do procalcitonin. So regarding the imaging, they recommend to obtain a plain radiography, as I said, to rule out any other pathologies. For septic arthritis, ultrasound, it is recommended. It can be done as a diagnostic and therapeutic modality. It is widely available, and it is inexpensive and non-invasive. For MRI, as I said, it is the gold standard, and they recommend the MRI over the CT and bone scintigraphy. Regarding the diagnostic invasive procedure, they recommend performing the or collection of the aspirate or biopsy in patients who didn't show any clinical improvement, and as well they recommend to send it for routine microbiological study, as I mentioned before, the culture, the analysis, and also aerobic, fungal, and aerobic, anaerobic, bacterial, fungal, and as well mycobacterium. So for a patient with bacterial arthritis, they suggest collecting the synovial fluid from the joint by erythrocentesis and start prior to starting to the antimicrobial therapy. And as well, they recommend perform the analysis, WBC count, and routine microbiological cultures. So the empiric antimicrobial therapy, it depends. If the patient is ill-appearing or have rapidly progressive infection, they recommend to start the antimicrobial therapy as soon as possible, rather than withholding until the invasive procedure to be done. And if they are clinically not ill and well appearing upon presentation, the withholding antimicrobial therapy can be done, but not exceeding 72 hours until and the patient should be hospitalized prior to the intervention. So what antibiotics needed to be done? It depends on the organism. Usually, if in both bacterial arthritis and hematogenous osteomyelitis, they recommend using empiric antimicrobial therapy active against Staph aureus. And children younger than 4 years of age, they recommend to use to include the Kingella kingi in consideration prior to as part of empirical therapy to be included. For the definitive, for identified pathogen, the recommendation is to use the narrowest spectrum, the lowest adverse effect, and the most favorable tolerated by the host. And if there is no identified bacterial, we should include the most likely causative organism. with the spectrum comparable to that in which patient can show to that when we started like empirical therapy and the patient showed improvement, we'll continue in the same antibiotics, and we need to consider the adverse effect and also the most favorable by the host. But it is the outpatient parenteral antimicrobial therapy. So transition to oral antibiotics, it's favorable over the OBAT, and if the patient showed clinical improvement. However, if the child didn't have oral option or there is no didn't tolerate and the oral therapy it's not feasible, OBAT it is better than the patient acute care hospital stay for the total duration of the therapy. So the duration usually in acute bacterial arthritis, if there is no osteomyelitis and the patient showed rapid clinical and laboratory improvement, the recommendation is to give the total duration of antibiotics parenteral plus the oral 10 to 14 days for common pathogens. They mean by common the Staph aureus, Staph pathogens, and Streptococcus and Haemophilus influenza type B. But if it's multi-drug resistant organism, which is or different unusual organism, usually we tend to take longer courses. So for hematogenous osteomyelitis, it is especially for a Staph aureus infection, usually the suggestion it is 3 to 4 weeks duration rather than 4 to 6 weeks. So the invasive procedure, so if the child didn't have any improvement or he has sepsis or rapidly progressive infection, the recommendation is to do the debridement for the bone and any associated abscess as soon as possible after the diagnosis, rather than just using the antimicrobial therapy alone. So if the child has an abscess greater than 2 centimeters, also there is a suggestion to do debridement rather than treating with medical therapy alone. So do we need the intrasurgical antibiotics? They recommend against it, and also in the osteomyelitis and as well in bacterial arthritis. So in the same here for therapeutic invasive procedure, if the child demonstrates a poor response within 48 to 96 hours, like he has continued fever, persistent bacteremia, or rising CRP, they recommend performing MRI if not previously obtained to rule out any complications or associated osteomyelitis. So if he needed additional invasive procedure, it has to be done to ensure that adequate source control. So this is my last slide, and so if the patient experiencing primary treatment failure or early or late recurrence for both osteomyelitis or bacterial arthritis, it is needed to be assessed the adequacy of the antimicrobial regimen, also the adherence to the antibiotics, and if there is any need for joint debridement or irrigation before deciding to broaden the spectrum or even restarting the antimicrobials. Another, if the patient has late or recurrent, they need additional diagnostic evaluation for possible adjacent osteomyelitis, along with any need for surgical intervention and therapeutic and diagnostic purposes. And this I conclude, and really thank you for having me, Dr. Nabil.
Thank you so much, Dr. Omar, for your excellent presentation. Actually, there is no someone to ask. We will take just a 5 minutes break, and then we will resume in our usual time, 6:45 we will resume. Okay, أستاذ علاء؟
تمام دكتور.
يلا اوكي سلام. يلا يا استاذ علاء. استاذ علاء. يا احمد سعيد معانا.
ايوه يا فندم معاك.
وكان ستارت كده يا استاذ احمد الستريم بتاعك ونبدا ان شاء الله.
السلام عليكم ورحمة الله. I want
لحظه
to
بس هقدم سعادتك الاول لحظه.
wait.
Okay, we'll start our second session for the second day. We'll have some changes because there is some speakers they could not attend on time. So our next speaker will be Dr. Ahmed Saeed. Dr. Ahmed Saeed is a professor of pediatric surgery in Al-Azhar University in Egypt. And he is a consultant of pediatric surgery in Saudi German Hospital, Riyadh. Dr. Ahmad will give us a lecture about new insights in treatment of Hirschsprung disease. Okay, Dr. Ahmad, shukran for being with us. And you can.
Yes. Assalamu alaikum warahmatullah. Our topic today is to discuss the new insights in the management of Hirschsprung disease. Of course, there is no disclosure. Our objective is to understand the diagnosis of Hirschsprung disease, recognize the key signs of the disease and other conditions mimic it, describe the diagnosis of the Hirschsprung disease, understand the surgical treatment, and recognize long-term outcomes, concerns, and how to treat. The historical review, the disease discovered by Harald Hirschsprung in 1887. He was a pediatrician from Copenhagen. He presented two cases and entitled constipation in newborn due to dilatation and hypertrophy of the colon. He thought that the pathology in dilated colon and it's strong, so both cases died. Erin Price described the correct pathology, that the problem in the spastic ganglionic segment in 1946. Between 1887 and 1946, most cases died from enterocolitis. Swenson did the first transabdominal excision of the ganglionic segment, and many pediatric surgeons not follow the principle of Swenson because they are not stuck to the rectal wall. So many complications occurred, and Duhamel came after that in 1956. He did the first successful transabdominal retrorectal pull-through, and Suavi did the first successful transabdominal pull-through in 1960. Jefferson did the first assisted laparoscopic pull-through in 1995. And Delatour did the first successful transabdominal pull-through. The incidence of Hirschsprung is 1 to 5,000 live birth. It's more common in male. The incidence is 4 to 1, and it's equal 1 to 1 in long segment Hirschsprung disease. The Hirschsprung disease runs in family, so in most cases there is family history, about 2 to 9%, and associated with 15% genitourinary symptoms. The ganglion cells is the enteric nervous system of the colon. They contract and relax the colon. It's derived from the new outer part of the neural crest cells. The neural crest cells migrate to different sides of the body. One of them is the pharynx, and migrate from the pharynx in craniocaudal direction and make colonization of the whole GIT. If there is arrest due to any cause, the earlier the arrest, the longer the segment of Hirschsprung disease. The neural crest cells affected by many genes, the differentiation, proliferation, migration, and the survival affected. We will discuss those genes later on. There is a question, why are the ganglion cells not there? They don't get there because differentiated or maturated, or they get there but don't survive due to an hospital microenvironment. The Hirschsprung disease associated with many syndromes like trisomy 21, Waardenburg syndrome, MIN2A, and the congenital central hypoventilation syndrome. There are many genes incriminated in the pathogenesis of Hirschsprung disease because they are affecting the neural crest cells, like red gene, which is located on chromosome 11, glial-derived neural factor, endothelin, SOX10, and FOX2B, SMAD interacting protein. We are classifying the Hirschsprung disease upon the position of the transitional zone. The transitional zone is hypoganglionic area between the dilated segment and the spastic aganglionic segment. So all the types of Hirschsprung disease share that the rectum is aganglionic. So we are taking rectal biopsy. If the transitional zone is present in the rectum and sigmoid colon, it's fortunately considered short segment Hirschsprung disease and present in 80% of cases. If the transitional zone is proximal to the splenic flexure, it's considered long segment Hirschsprung disease. If the transitional zone is in the ileum and affecting the whole colon, it's considered total colonic aganglionosis. And if it's affecting more than 5 centimeters of the ileum, it's considered small intestinal aganglionosis. And in total intestinal Hirschsprung, it's affecting less than 20 centimeters of ganglionated intestine beyond the ligament of Treitz. So how to approach the diagnosis of Hirschsprung disease? We have to take a history and physical examination, doing the radiology X-ray and contrast enema, taking rectal biopsy, suction or full thickness, and there is many debates about anorectal manometry. 90% of the cases present in the neonatal period by the common scenario failure to pass meconium in the first 24 hours. Many cases presented with distal bowel obstruction or cecal perforation, and about 10% of cases presented with enterocolitis and failure to thrive. About 10% of the cases presented later on by abdominal distension and unmanageable chronic constipation, also delayed growth, and most of them usually short segment. So the common scenario that we are receiving a call from the NICU that there is a patient with abdominal distension with delayed passage of meconium, and sometimes there is bilious vomiting, and about 10% of the cases presented with enterocolitis and foul-smelling diarrhea. The differential diagnosis of newborn with no meconium after 24 hours, we have to exclude first that there is anorectal malformation. Also, the differential diagnosis is meconium plaque, especially in diabetic mother and preterm patient. And colonic atresia, also ileal atresia and meconium ileus. Also, if the mother received opioids or received magnesium sulfate intrapartum, also in hypothyroid patient. Regarding the imaging, we have to do plain X-ray and water-soluble contrast enema. There is no rule for barium study in those patients. In this picture, there is a gross dilatation or gross distension of the intestine with empty rectum, delineating that there is distal bowel obstruction. The contrast enema, there is many precautions for the contrast enema. We have to do it without preparation and without examination, without digital rectal examination, and after deflating the balloon, searching for the transitional zone site. If it's present in the rectosigmoid, like this patient, we have to take a lateral view. The lateral view is at most important, and calculating the proportion between the diameter of the sigmoid and the rectum, which is inverted in Hirschsprung disease patient. If the transitional zone is proximal to the splenic flexure, it's considered long segment Hirschsprung disease. In this picture, we see a question mark, which indicating that there is total colonic aganglionosis, and we have to see the reflux of dye to the ileum. In this picture, we cannot differentiate either it's total colonic ganglionosis or small left colon syndrome or meconium blood. So about 10% of the cases, there is no transitional zone. So we have to do delayed picture after 24 hours to see that there is delayed emptying of the dye. There are many debates about the role of anorectal manometry for diagnosis of Hirschsprung disease. If we increase the pressure in the rectum by inflating the balloon, in normal baby, the sphincter should be relaxed to pass stool. So after inflation of the balloon, the sphincter pressure is decreased to pass the stool. This reflex is absent in Hirschsprung patient. It's role doubtful in neonates. It may be useful in older children with short segment, and it's also operator dependent. So from the history, if there is delayed passage of meconium, bilious vomiting, abdominal distension, symptoms of enterocolitis, this is suggestive of Hirschsprung disease. So we have to proceed for the golden rule rectal biopsy, plus or minus anorectal, and contrast enema. The suction rectal biopsy can be done by suction rectal biopsy or full thickness rectal biopsy. This is the gold standard for diagnosis of Hirschsprung disease, and suction rectal biopsy can be obtained from infant below the age of 6 months. After 6 months, there is redundancy of the mucosa, so we will take the mucosa only and will be inadequate. So in suction rectal biopsy, we are obtaining the mucosa and the submucosa. We have two plexuses, one of them submucosal plexus and myenteric plexus. In suction rectal biopsy, we are taking the mucosa and the submucosa. In laparoscopic biopsy, we are taking the myenteric, and of course, we are taking the submucosal and the myenteric plexus in full thickness rectal biopsy. If we obtained only mucosa, it will be inadequate biopsy because we are not taking the submucosal or a myenteric plexus. So the suction rectal biopsy will take the mucosa and the submucosa. It will not take the myenteric plexus. The ideal site to obtain our rectal biopsy, either suction or full thickness rectal biopsy, is 1.5 centimeter above the dentate line. This is the enoderm, which is a ganglionic and transitional epithelium. This is the dentate line, and 1.5 centimeter above, we have to take our biopsy. If we take the biopsy so proximal, we may miss the short segment Hirschsprung disease, and if we take it distal, it will be a ganglionic or hypoganglionic of the anal canal. Also, of utmost important to preserve the anal canal during biopsy or any pull-through procedure, because excision of this $1 million epithelium, it may lead to fecal incontinence. After obtaining the suction biopsy, we have to keep it on filter paper and immerse it in saline and send it immediately to the pathology and fix it immediately after reaching the pathology department to avoid damage of the specimen. The full thickness rectal biopsy can be obtained after 6 months because there is much redundancy of the mucosa. And if we did the suction rectal biopsy, will take only mucosa, which will be inconclusive suction rectal biopsy. Also, we can take the full thickness in sufficient suction rectal biopsy. It's really a true operation. This nice slide by Lone Star showing this is the anal canal and the dentate line. We will hide the anal canal to preserve it and trying not to destroy the anal canal. And taking our full thickness rectal. We want to emphasize that frozen section cannot diagnose Hirschsprung disease, but can rule out Hirschsprung disease. So, intraoperative, if we take a frozen section and there is long segment Hirschsprung disease, we have to wait for permanent section to be sure that it's a ganglionic, because we cannot excise the colon upon the frozen section. The histopathology report should be include if there is ganglion cells or not, if there is hypertrophy of nerve bundles and the diameter of the nerve bundle. Also, immunohistory, histochemistry, very helpful in diagnosis, especially in suction rectal biopsy, and acetylcholine activity should be mentioned in this report. In the picture on the left side, there is no ganglion. In picture B, there is hypertrophy of the nerve bundles. In Hirschsprung disease, there is activity, increased activity of the acetylcholine. In normal patient, there is no increased activity of the acetylcholine. There is absence of calrintine in Hirschsprung disease. So, how to reach the tissue diagnosis? This is the algorithm for diagnosis of Hirschsprung disease. Of course, if there is ganglion cells, it's not Hirschsprung disease. If we obtain mucosa only or the levels less than 50 levels, it will be inadequate biopsy. If there is hypertrophy of the nerve trunk, it's suggestive of the Hirschsprung disease. Also, if there is increased acetylcholine activity and absence of calrintine, it's of course Hirschsprung disease. If there is no hypertrophy of the nerve trunk, it may be inconclusive biopsy or long segment Hirschsprung disease. So, what are the surgical options? What we will do for this patient? Ostomy with future pull-through or primary pull-through from the start, or will we do rectal irrigation and learn the family how to do and send the patient home with future pull-through? It should be individualized and we will discuss everyone. This leads to us to ask ourselves, is a routine colostomy necessary? Routine colostomy not indicated except in several cases, and severe persistent enterocolitis not responding to conservative treatment or rectal irrigation, if there is cecal or appendiceal perforation, in the cases of lack of accurate pathology support, also if we suspect long segment Hirschsprung disease and a delayed presentation of the Hirschsprung disease when there is disparity between the proximal and anus. The principle for all pull-through surgery is to excise the aganglionic segment, preserving the anal canal and transitional epithelium, and pull-through of the normal ganglionated colon and doing the anastomosis. So we will do in the neonatal period or after the neonatal period, this paper published 2017 and discussed the pull-through in the neonatal period and concluded that doing the procedure during the neonatal period, in spite of it's easy to do with, and because there is no disparity, it will lead to many complications like perianal excoriation, anastomotic stricture, leak, postoperative enterocolitis, and incontinence. So they recommend doing the pull-through after 1 month to 3 months. The surgical management, Swenson don't leave behind any aganglionic segment. He resect all the aganglionic segment trans-abdominal or trans-anal. In a SWABI operation, he left back the aganglionic cuff muscle. In Duhamel procedure, he left back the anterior aganglionic column. In transanal pull-through, he did Swenson or SWABI and laparoscopic assisted pull-through. Also, there is Swenson, SWABI, or Duhamel. This is SWABI operation. The red one is the cuff muscle. He pulled through and preserved the anal canal and sphincter. So this cuff muscle may be narrow later on and causing obstructive symptoms. In Duhamel procedure, the anterior aganglionic segment may be enlarged and making spare and compressing the ganglionated segment and causing obstructive symptoms. So we want to emphasize that in Swenson operation, we have to stick to the wall to avoid injury to the pelvic structures like the seminal vesicles, ureter, and prostate, and the vagina in female. In SWABI operation, we are operating inside the wall. And in Duhamel operation, we are doing retrorectal pull-through. After the pull-through, this is the Swenson operation after excision of the aganglionic segment. He don't leave behind any aganglionic segment. The green one is the pull-through colon. He did the anastomosis nicely, 2 centimeters above the dentate line, preserving the anal canal and sphincter. In Duhamel procedure, he left back the anterior aganglionated colon, which may be enlarged and making spare and obstructive symptoms. And in SWABI operation, he left back the cuff muscle, which may cause obstruction later on. The role of minimally access surgery or laparoscope, it started 1995 by doing the mapping of the colon and to dissect the pelvic part of the colon and dissect the splenic flexure. We can do SWABI, Swenson, or Duhamel by the laparoscope. There are the sites of laparoscopic ports. Delatour should be commended for his operation transanal pull-through. He did the operation from the anus. He hid the anal canal at the marking 1.5 centimeters above the anal canal, taking multiple sutures and start mucosectomy and the full thickness excision of the rectosigmoid colon and doing the anastomosis calibration. The postoperative consideration, the patient can start gradual feeding after regaining of the intestinal motility. We want to emphasize that there is no rectal examination for 2 weeks post-operative. The patient family should learn how to do irrigation pre and post-operative. And if the patient develop Hirschsprung associated enterocolitis, should start rectal irrigation. There is statement said, with good operation, all children with Hirschsprung have a great results. Actually, this is not correct statement because there are many unavoidable complications. So we will discuss the short-term outcome of Hirschsprung disease complication, leak, peritonitis, dehiscence of the anastomosis, pelvic abscess, and retraction of the pull-through. Regarding the long-term outcome of the Hirschsprung disease, persistent obstructive symptoms, the patient will be presented by constipation, abdominal distension after the operation, or if we injure the anal canal, will be presented by soiling or enterocolitis. The persistent obstructive symptoms may be due to mechanical obstruction or incomplete resection of the ganglionic segment, or the pull-through segment. There is dysmotility of this ganglionated colon, or there is internal anal sphincter achalasia, or the patient hold himself by stool holding behavior. So the causes of mechanical obstruction may be stricture at the site of anastomosis, or twist of the pull-through segment, or spare of Duhamel, or narrow long cuff muscle of Suavi. To approach the diagnosis of mechanical obstruction, we have to do examination under general anesthesia and do the contrast area. In this photo showing that there is stricture at the site of anastomosis. And this is the iatrogenic twist of the pull-through. The problematic Suavi cuff in Hirschsprung disease, it may cause obstructive symptoms and obstruct the ganglionated segment, so it should be splitted and not leaving much cuff muscle in a Suavi operation. This is a spare of Duhamel and should be resected by stapler. Also in this picture, there is stenosis at the site of anastomosis post-Suavi. This picture delineates the spare of Duhamel, which may compress the ganglionic colon and causing obstructive symptoms. In this picture, there is a twist of the pull-through colon. So how to approach the diagnosis of persistent obstructive symptoms? After doing the examination and contrast anemia, if there is stricture, we have to dilate, injection of mitomycin, or even redo the pull-through. If there is no stricture, we have to take a rectal biopsy. If there is no ganglion cells, this means that incomplete resection of the ganglionic segment, and we have to do the redo pull-through. If there is ganglion cells, we have to do colon transit time and the motility workup. If it's normal, we will try Botox. If it's a focal segmental affection, we have to resect. If it's abnormal generalized, we will do bowel regimen. This is a nice picture of internal sphincter achalasia, and after injection of the Botox, the sphincter will be relaxed and obstructive symptoms will be improved. The soiling post-operation for Hirschsprung may be due to iatrogenic injury of the anal sphincter leading to poor muscle control, or due to iatrogenic also excision of the $1 million transitional epithelium of the anal canal. It should be kept without injuring of the anal canal or epithelium. It will lead to poor sensation, and the patient cannot differentiate between gas or stool. Also, there is a cause for soiling post-through operation. due to hypomotile colon or hypermotile colon. Are the sphincter good? This is actually on the left side, good sphincter. The sphincter coapted, we cannot see inside, and the perineum is not flat. In this picture on the right side, we can see inside, and the perineum is flat. We want to emphasize that damage of the anal canal and excision of the transitional epithelium will leave an incontinent patient. So after examination, this is picture after surgery. This is the anal canal dentate line. It's preserved and nice. In this picture in the middle, it's incomplete excision. This is the part of the dentate line and the remaining excised iatrogenically. This is complete excision of the transitional epithelium. So in pseudo-incontinence patient, this is ganglionated pull-through colon, but it may be very lazy, accumulating a lot of stool inside with overflow incontinence, or maybe very fast and overcoming the sphincter. To treat the soiling, we have to understand the cause, and in true incontinence, we have to give constipating diet and lopramide and enema either retrograde or antigrade. In pseudo incontinence, we have to do the contrast enema and see if it's hypomotile or hypermotile. If it's hypomotile, we have to accelerate this ganglionated colon by giving stimulant laxatives or high fiber diet and stool softener. In hypermotile colon, we have to give constipating diet and lopramide to slow this hypermotile colon and do toilet training and behavioral therapy. And also the pelvic floor physical therapy is of utmost importance. We have to avoid enemas in cases of stool holding behavior, and finally, in intractable cases, we have to do colostomy. This algorithm for a Hirschsprung patient with soiling post pull-through. Regarding the Hirschsprung associated enterocolitis, actually the etiology is unclear. It may be due to defect of immunoglobulins or dysbiosis or secretions of the colon. This is the most common cause of mortality before or after operation. Actually, the enterocolitis, it's considered the nightmare for all surgeons. The American Pediatric Surgery Association classified the Hirschsprung upon the symptoms and the radiology to 3 grades.
Still a lot of time يا دكتور أحمد.
لا خلاص.
طيب يلا.
Enterocolitis management. In acute enterocolitis, we have to decompress the colon and doing rectal irrigation and broad spectrum antibiotics. In chronic enterocolitis, we have to search for distal obstruction and doing colostomy in resistant cases. What is the difference between enema and irrigation? Irrigation, we will calculate the amount, inject small amount, and let the catheter inside until the whole amount enter, because the patient of Hirschsprung cannot expel the saline. Total colonic aganglionosis, the transitional zone present in the ileum, and this is the spastic part. This is the appendix and cecum. There are much debates about the timing of surgery for total colonic aganglionosis. Some authors recommend after stool thickening, which occurred after 6 months, and some recommend after urine toilet training. This paper published November 2021 and recommend doing the Hirschsprung operation for total colonic aganglionosis after 2 years. to avoid the massive complication. This is unmanageable napkin dermatitis and need permanent ileostomy. Our preference is to do after 2 years and do short Duhamel or Suavi or Swenson. Permanent ileostomy in severe massive napkin dermatitis. There are 2 operations of historical interest, Martin and Kimura. Also, ileoanal anastomosis has a much complications like enterocolitis. Near total or total intestinal ganglionosis fetal condition. Ziegler did myectomy and myotomy, and if it's of historical interest. This patient should receive TBN and intestinal lengthening procedure and a small intestinal transplantation. The future directions is to obtain the embryonic stem cells and CNS derived progenitor cells and inject them in the patient. But the question, they will migrate or not, they will mediate peristalsis or not, it's safe or not, it need much research work. And need large multi-center database. Thank you.
Thank you so much, Professor Ahmed, for your long, detailed, but very nice lecture. It was great. Thank you so much.
Thank you.
Now we will move to our next speaker. Our next speaker will be Dr. Warda Ali. Dr. Warda is a consultant and the head of the pediatric department in Ahmed Maher Teaching Hospital in Egypt. Dr. Warda will give us a speech about challenges in the diagnosis of neonatal anemia. Okay, Dr. Warda, تفضلي. Thank you for being with us.
Thank you. Thank you a lot, Dr. Nabil, for giving me the opportunity to share in such wonderful حقيقي ومفيد جدا very fruitful webinar. كل سنة احنا بنستناه حقيقي. We are waiting for this lecture and this webinar every year. حضراتكم شايفين السلايدز والصوت كويس صح؟
تمام كله تمام. شكرا الله.
I'm a neonatologist. Today my topic will be concerned with neonatal anemia. Actually, what's the challenges facing us as a neonatologist in diagnosing neonatal anemia, and to do with this, we will approach by an evidence-based approach to diagnose anemia in neonates. I have nothing to disclose. My objective will try to cover the definition of anemia, severe anemia, using the evidence-based reference interval, why it is important to have a clear definition for anemia. I have to go through the neonatal iron balance. I will try to answer a very important question. Does the source of blood make any difference in the CBC laboratory result? Let's start together. Anemia is an ancient word called anemia. An is not, anemia is blood. That is to say, it means lack of blood. This lack of blood is not a simple variable which a patient either have or does not have. It is a spectrum ranging from trivial to fatal condition. Lack of blood could be due to hypovolemia, deficient number of RBCs within the normal blood volume, or a deficient in the function of the hemoglobin. It can be present before or at birth, or even it will develop rapidly, slowly during the first hour, days, or weeks after birth. To diagnose anemia, we have to diagnose the severity, classify it as moderate or severe anemia, understand its cause, whether it is reduced RBC production, RBC loss, whether due to hemorrhage or hemolysis, or it is a combination of the two mechanisms. It is very important for a neonatologist to precisely diagnose anemia. However, there is virus confusion arise because there is virus definition. Everyone define anemia at a different level. Why this happened? Let us try to understand why this is happening. Why is this happening? An infant delivered at 24 weeks gestational age will have anemia with a blood hemoglobin concentration lower than a hemoglobin concentration defining anemia at term. Very logic. The preterm will have different from that of the term. This is the first variable. The second variable, a hemoglobin concentration dividing anemia at term birth is higher than that defining anemia in the same infant, but 2 months later after birth. Then we have two variables, the gestational age of this baby, whether preterm or full term, and the second is the age of this baby after birth. For sure, the third trimester is the timing where we are giving the storage, a fetal hemoglobin level and hematocrit counts gradually increase during this third trimester, that is, say, after 23 weeks gestational tutor. Then the definition of anemia has to be according to the gestational age. At 23-weeker neonate, anemia is defined by a hematocrit below 30% or hemoglobin level below 10.2 gram per deciliter. On the other side, at 40 weeks, the hemoglobin value should be higher, and anemia is defined by a hematocrit below 41.5% or hemoglobin level below 14.2 gram per deciliter. Thus, the blood cell count of neonate must be interpreted according to the reference interval, and this reference interval is based on gestational age and postnatal age. Without this consideration, a diagnosis of anemia at birth can be confusing, inaccurate, and according the decision-taking will be not so accurate. By this, we can define hemoglobin anemia by a hemoglobin level or hematocrit plotted below the 5th percentile according to the reference interval. Moderate anemia if the hemoglobin value between 1st and 5th percentile. Severe anemia if it is below the 1st percentile. Here are the references, I will present them. Here are the reference interval drawn by the gestational age. This is the hematocrit, 1st percentile, 5th percentile, and even the 95th percentile. The same for the hemoglobin. If you put this results in, can tabular the data and put it in a table for much easier interpretation. We have to use this curves and put it at the NICU to enhance the clarity of the medical records, the research report, and for every day while we are taking the decision for the neonate in everyday work, precise interaction in daily work in the NICU, and record and to reduce the ambiguity in medical legal policy. If we are trying to interpret why there is changes in the hemoglobin in hematocrit, let's revise with حضراتكم some of the pitfalls happening. In the first 6 hours after birth, during this first few hours after birth, hematocrit and hemoglobin level, the literature inform us that it's typically increased by 5 to 10%. It's not a fault from the lab if we are repeating. Why? It has been postulated that might be due to placental transfusion during labor and delivery, followed by extraction of water from the vasculature to reduce the blood volume back to the pre-transfusion normal. If during the first hours, we can disturb this by what we are giving, receiving large volume of intravenous fluid, or the frequent sampling we are taking from the baby, phlebotomy, loss of or hemorrhage, hematocrit will result in fall during those first hours. Then, after anemia during the first month after birth, during these weeks after birth, the hemoglobin and hematocrit gradually fall. What do you think why this is happening? It is happening because there is reduced erythropoiesis, dilution as the body weight and blood volume increase, and the shorter RBCs, as you know, that the neonate versus that of the adult. It has been mentioned that the reticulocytic count at reduced erythropoiesis at birth, the reticulocytic count reference interval is from 4% to 7%, but after several days, it will be from 0 to 1%. Let me revise مع حضراتكم the reticulocyte. What are these reticulocytes? Let's remember some of this knowledge. The reticulocytes are the youngest erythrocyte released from the bone marrow into the circulation. It's mature for 3 days within the bone marrow, from 1 to 3 days in the bone marrow, and then released to the circulation to circulate within 24 hours up to 2 days before becoming mature erythrocyte. This is the bone marrow, and then the reticulocyte 2 days inside to mature and get outside for to stay and mature to be red blood cells. And for neonate, let me remind حضراتكم, it's not 120 days, it is from 60 to 90 days. It has a characteristic network alignment and granules this reticulocyte. Why I'm mentioning this and reminding حضراتكم بيها علشان reticulocyte hemoglobin content. This is one of the RBC's indices, measurement of cellular hemoglobin concentration. This reticulocyte hemoglobin content provides an indirect measurement of the functional iron available for new red blood cell production over the previous 3 to 4 days. It's available in the market. It reflects the latest hemoglobin census status. Then it will give me an idea how is hemoglobin sensitized during the previous few days. Not affected by any factor other than those participating in iron metabolism, as long as there is no abnormality in the hemoglobin census. And for sure, my lecture is not concerned with genetic disease of the hemoglobin. It's useful for detecting the therapeutic effect of iron supplementation if I'm giving this infant iron. Why I'm dealing with this or giving reflection on this point? Because iron deficiency is a common problem in neonates. It is in its early stage, the deficiency will go unnoticed. This baby is unnoticed to have iron deficiency. I don't want to diagnose iron deficiency when anemia develops. I find anemia, and then what's the cause of this anemia? I realize there is iron deficiency. It is important to diagnose iron deficiency early. That is before neonate had developed iron deficiency anemia. Why? Because adequate treatment during the early stage, before anemia has developed, might prevent lasting adverse neurodevelopmental deficiency. What's the relation between iron and neurodevelopmental deficiency? Because iron is required for the development of all organs, including the brain. Normally, this iron, 75% of neonatal body iron is transferred in the 3rd trimester. Then preterm babies, the preterm neonate are at increased risk of congenital iron deficiency, and we have to put it in our mind. If you want, we said that the preterm, but there is a balance. Factor predisposing congenital iron deficiency versus factor improving iron state. If you have this fetal neonatal iron balance starting intrauterine and continuing after birth, the issues that improve, factors that improve the iron status and factors that decrease. There are several factors, for example, that improving the delay clamping. We have to remind حضراتكم بيها. To minimize the phlebotomy, minimize the sampling where we are every now and then taking sampling from our neonate. We might need the RBC's transfusion. On the controversy, one of the very critical important is the prematurity. The diabetic mother, there are several factors will contribute to the decreasing the iron balance. Thus, screening iron status in the NICU is defining iron status precisely in at-risk infant, and treating those with iron deficiency appropriately should be considered as a neuroprotective strategy. Iron deficiency will go through stages: inadequate to meet the needs, then definable stage of iron deficiency, then there is a negative iron balance, depleting the iron stores, and then iron stores become critically ill, we evident by falling in the reticulocyte hemoglobin content. This is a stage, this mild stage of iron deficiency is termed iron deficiency erythropoiesis. At this stage, there is a decrease in the reticulocyte hemoglobin content, the percentage of the microcytic erythrocyte. This microcytic erythrocyte increase, not any erythrocyte, and the percentage of hypochromic erythrocyte increase. Then I have an erythrocyte with increased percentage in its microcyte and the hemoglobin. At that stage, the main corpuscular volume and main corpuscular hemoglobin are normal. Followed then after this stage, followed by falling in the main corpuscular volume and main corpuscular hemoglobin. لكن اللي أنا كنت بتكلم عليهم اللي هو المايكروسيتيك erythrocyte. It is an electronic measurement of the percentage of erythrocyte with main corpuscular volume less than 60 femtoliter. That is to say, I'm quantifying the erythrocyte microcytosis. The same idea, the hemoglobinized red cells, electronic measurements of the percentage of erythrocyte with main corpuscular hemoglobin less than 17 picogram per cell. Thus, I'm quantifying erythrocyte hypochromia. There's conventional indices of iron. It's not my topic. Again, the microcytic erythrocyte has a reference interval, 50%, 5 percentile. Again, the hypochromic erythrocyte, it has to be, again, put on the normal for age. Main corpuscular volume, again, and the main corpuscular hemoglobin. I'm very sorry for the noise I have, but I have no control on it. I'm very sorry. Okay, then we are defining erythrocyte microcytosis, hypochromia, using the main corpuscular volume, main corpuscular hemoglobin, microcytic erythrocyte, hypochromic erythrocyte. All this I'm trying to avoid diagnosing anemia. I don't want to diagnose anemia from the start. And again, congenital microcytosis, if the main corpuscular volume less than 5th percentile. Hypochromia, if the main corpuscular hemoglobin less than the 5th percentile, according to gestational age for sure. It's not only iron deficient, it's not the only cause, for sure. I'm putting it in my mind. Cause of the low main corpuscular hemoglobin, main corpuscular hemoglobin, there's other factors like alpha thalassemia, the congenital erythrocyte microcytosis, the hereditary spherocytosis presented with low main corpuscular volume at birth and the elevated main corpuscular hemoglobin concentration, and for sure, elevated main corpuscular hemoglobin concentration over the main corpuscular volume ratio. I'm putting them in my mind and having. Thus, let me go and collect all the data together. Conceptualization of the spectrum of iron deficiency in neonate and displaying how reticulocyte hemoglobin, main corpuscular hemoglobin volume and hemoglobin, microcytic hemoglobin, and the hypochromic erythrocyte, hematocrit, and hemoglobin can be used to define the severity of neonatal iron deficiency. Let us plot them and put it in one table. Here is this very illustrated. The first row, as you see, the first row is the where the iron deficiency. As you see, the reticulocyte hemoglobin content is low. Only the first finding to be found is the reticulocyte hemoglobin. While the microcytic erythrocyte is normal. The main corpuscular volume is normal. For sure, the hematocrit and the hemoglobin are normal. Then at later after stage that we have defining it as iron limited erythropoiesis. Here the reticulocyte will be affected, reticulocyte hemoglobin be affected, and start with the microcytic erythrocyte will start to be affected, but again the main corpuscular hemoglobin is normal, the hemoglobin in hematocrit. Later on, as you see, we'll go on by only we are sparing the hemoglobin in hematocrit, but there is affection of the main corpuscular volume as well. And finally, there will be defining iron deficiency and all are affected, but at that stage, we don't know what happened for the neurodevelopmental affection happened to this unit. This is, I think I sent for you my message, my clear message that we don't want to diagnose anemia from the start. I told you another question, does the source of the second part of my lecture will trying to answer, does the source of blood make any difference in the laboratory result? We have to consider the source of blood. Why? Because understanding this issue can avoid misinterpretation of test results. What we have as a neonatologist, we have many options to take the sample from umbilical cord artery to start at the early life, vein, capillary, from the capillary needle stick or the capillary puncture. Studies show that, زي ما حضراتكم شايفين in this study paired site where blood samples were drawn simultaneously for comparison of hemoglobin, and they found that the capillary is not much, it's from 10 to 15, more than the vascular. Values of erythrocyte samples obtained from a capillary source of neonate are typically 15% higher than those from a vascular source. Infant of lowest gestational age have the largest capillary venous difference, as when the gestational age decreased, then this difference will increase. Why? Might be because the very large size of the erythrocyte in those of the lowest gestational age, or a slower capillary perfusion at the lowest gestational age. It is helpful to have the sample size documented. This is my recommendation, that we have to, when we take sample, we have to document it in our records in the NICU. Otherwise, what can appear as trend in the rhythm might be actually nothing except difference in the sample size. Maybe it's of not very significant at this point. The venous cord hemoglobin is constantly but slightly lower than the arterial cord hemoglobin. Might be it's the fluid transferred to the fetus through the placenta into the umbilical vein. Maybe this is knowledge. It could slightly dilute the venous cord hemoglobin concentration, but I just mention it to collect the knowledge. Finally, my take-home message: anemia is a common problem in neonatal intensive care unit. Severe anemia is defined as value below the first percentile, moderate anemia if it's between first and fifth. Capillary source of erythrocyte samples are 15% higher than those from a vascular source. The reticulocyte hemoglobin content, mean corpuscular volume, mean corpuscular hemoglobin, microcytic erythrocyte, hypohemoglobinized red cells, hematocrit hemoglobin can be used to define the severity of neonatal iron deficiency, of course, to manage it. Adequate treatment during the early stage before anemia has developed might prevent lasting adverse neurodevelopmental deficiencies. This is some of my references. This is the main reference, and thank you.
Thank you so much, Dr. Ragda, for your excellent presentation, and we are happy for being with us.
Any questions?
There was just a question from Dr. Hala. I think she is your friend. She's asking about the cord milk. I answered already, but I want just to inform you also. Can cord milking improve the circulation in the preterm?
اوكي طبعا الكورد ميلكينج حضراتكم عارفين ان هو it's the new edition, a new update in the neonatal resuscitation. They first many years ago they have been forbidden milking, and now they again rediscussing the issue of milking to be considered, but no evidence base to confirm that milking can be used. But delay cord clamping is the main contributing factor to be used.
Yes, exactly. This was the answer.
اوكي اكيد طبعا حضرتك هتقولها. في اي اسئله ثانيه؟
لا شكرا جزيلا.
Thanks a lot. Thank you.
Thank you so much. طيب نروح بقى لمسك الختام مع our star بروفيسور دكتور عبد الله الشمراني. Dr. Abdullah Shamrani is a professor of pediatric pulmonology and sleep medicine in Prince Sultan Military Hospital in Riyadh. He is a professor of pediatric pulmonology or professor of pediatrics in Al Faisal University, and he is the chairman of the scientific committee for the pediatric pulmonology in the Kingdom. And he is the chairman of the scientific research committee in pediatric department in Prince Sultan Military Hospital. Dr. Shamrani will give us two presentations, so he has the time to close this day. The first one will speak about severe asthma in children, new era for biologics, and the second presentation will be about complicated pneumonia. So, Dr. Abdullah, you can start, and welcome. Thank you so much for being with us. We are honored to have a caliber like you in our symposium, and thank you so much. You can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Is my voice clear?
Yes.
First of all, I would like to thank Dr. Nabil Bersey and his team for inviting me to be with you for maybe third time or fourth time in a row. And أسأل الله التوفيق لي ولكل الزملاء. I would like to thank all the speakers, all the attendees, to attend this important conference. And I have chosen really two important subjects in pediatric. I would say my talk today is really heterogeneous, could be simple for the pulmonary field, but could be really complex for general pediatric. And I'm expecting majority of the attendees today are general. So I will try to stress about important message. As you know, the asthma is really highly needed at all levels. If you go to the emergency, one of the commonest presentation is asthma exacerbation. If you go into the clinic, the commonest case that being encountered is asthma at OBD. If you are in patient, the majority of patient has asthma plus chest infection. So pediatrician need to know what is the update about management of such cases. My talk, first talk, which is really the severe asthma in children, and I have selected the severe asthma. So the learning objective for the first talk is to know what do I mean by the severe asthma. Then I would like to know what could be the best approach in managing such cases. Then I will stress on the new era called phenotype, endotype, and how to choose the biologics and how to assess the work of the biologics. So these are the outlines. So you should know certain definition. Okay, then you need to know the treatment of asthma at OBD, because this is the basic, especially now, the step 4 and the step 5. And you need certain background about the epidemiology of severe asthma. And now the systemic approach that you need to focus with me through my lecture, just to know one step by step till how to tackle the management of severe asthma. Then, and then the conclusion or the home message. Just that you know that the majority of asthma are mild, 75% of cases are mild. That means step 1 and step 2. Okay, so with education, Ventolin and mild piloxotide, mild inhaled corticosteroid will control the asthma. When step 3 and step 4, this is called moderate. So now my talk will be about the 5%, and you will see it is just only 5%, could be more than this or could be less than this. So my focus about the 5%. Okay, so why this 5%? I forget the others. We will see. So the definition that I would like you to know, what do we mean by the uncontrolled asthma? So uncontrolled asthma, we are focusing here about symptoms. So patient has what? Night cough, like daytime cough, limitation of activities, frequent use of bronchodilator, frequent use of steroids. So there is a scoring system how to assess the uncontrolled. For example, the commonest for older kids called CAF, which is the asthma control test. And there is a scoring. For example, if the scoring below 19 out of 27, this is poorly controlled. And the kids less than 5 years, the track called test for respiratory asthma control in kids. If it's less than 80%, this patient is uncontrolled. So uncontrolled, we mean symptom. Now, this is the CAF and this is the track. Now, what is the definition of difficult to treat asthma? You might hear about this terminology in literatures. That means this is the GINA, which is the main famous guidelines for treating asthma, or our local guideline, SINA, Saudi Initiative National Guideline for Asthma, is limited for step 4 or step 5. So patient on step 4 or 5 and still symptomatic. So this is called difficult to treat. And then we will try to investigate why. Then the last terminology that you should know it. Okay, what is the definition of the severe asthma? Severe asthma, that means still patient uncontrolled. So still symptomatic with night cough, daytime cough, and etc. Despite maximum therapy, and we will know now what's the meaning of maximum therapy, and we control all the contributing factors like the technique, risk factor like the comorbidities. Okay, so what do I mean by the maximum therapy for severe asthma? There is no universal definition, but one of the best is the ERS or ATS. Okay, patient asthmatic on high dose on inhaled corticosteroid. Despite this, he still needs second controller. Is there any problems in the message?
No, we can hear you. That's okay.
So patient asthma is in high dose of inhaled corticosteroid plus therapy or he's requiring systemic steroid. So
دكتور مصطفى معلش ميوت المايك بتاعك. دكتور مصطفى السعيد.
So what is the mean of what is the definition of high dose inhaled corticosteroid? So it's different depends on the what type of inhaled steroid that we are using. In Saudi Arabia here, we are commonly using, for example, the orange one. So for the older kid, more than 5 years is 500 microgram. While for the younger age group, which is less than 5 years, in literature it is still scanty, but I would say it is more than 400 mic. So asthma, so still more than 500, more than 500 mic. In younger age group, more than 500 age group. Okay, so this slide is really very crucial by all means for any pediatrics. So treatment of asthma to OPD. I put this slide because I need to focus on 4 and 5. So we are getting the low dose inhaled corticosteroid, okay, plus SABA as needed. And in here, we prepared the inhaled corticosteroid, for example, the one fluoxetine 125 PD. When you go now for the second step number 2, low dose inhaled steroid. So low dose inhaled steroid 250. So that means we prepared fluoxetine 125 1 buff PD. Okay. When you go for step number 3, 4 choices, but this, for example, the SABA, Seretide 125 1 buff PD, or you can start very low dose formoterol, which is the marked system before. Or there is alternative. For example, you can double the inhaled steroid, low dose inhaled steroid, so you can double the fluoxetine 2 buffs PD, or you can add the Montelukast, the singular, to the low dose inhaled corticosteroid. So there is multiple choices, and the evidence here is A, okay, but the best is either the MART or Seretide. The step number 4 is the moderate inhaled steroid plus the LABA, which means Seretide 125 2 buffs BD. Okay, in the so this is step number 4. Now step 5, which is now our talk will focus on this area when we are in using high dose inhaled steroid plus the biologic and systemic steroids. So the SINA is almost similar to the GINA, but they are more generous, and I like their recommendation because in here they are more generous in the MARC protocol, and they gave the physician a chance to add Montelukast in step number 4, okay, which is different from the GINA. And in here, it's the same. The step number 5 is the biological and systemic steroid. And usually step 4 and step 5, this should be seen by the subspecialty like pulmonologist. So this is now the older age group, more than 5 years. Now we will go to the younger age group. Majority of the asthma is younger age. Okay, so the step number 1 is be sure about the diagnosis of asthma. And in here, step number 2, low dose inhaled steroid. So low dose inhaled steroid, I used many years, fluoxetine 200. So that means fluoxetine 50, 2 buffs BD. But now there is, I see many scholars, they are saying it is 100, 200, 400. So it is, the low dose in here could be ranging from mild, from 100 mic to 200 mic. The moderate dose this is called the step number 3. However, the SINA and GINA, they are coping.
لو الاختبار والحمد لله انت الاشعه الصدري كويسه، فهو بس الدكتور عاصم ده استشاري
So the step number 3, which is medium dose, as highlighted by Gina and Sina. However, I don't like their approach. I prefer there is many other guidelines like SINE, New Zealand, Japan, Australia, India, and there is an Egyptian famous physician, Ilham Hosni. She tackled all the guidelines, and the majority. I like the approach of the SINE, New Zealand, Australia, where the step number 3, low dose inhaled steroid plus montelukast. If you are worried about montelukast, about the side effect of neuropsychiatry or sleep problems, alert the patient using the montelukast. But I like this one. Then step number 4, the moderate dose plus leukotriene. And as you see in here, there is no rule for biologics. And the step number 5 is the steroid. So this is a summary, and I would say important message for general pediatrics. Now I will go back now to the severe asthma. Severe asthma is a common in the country and common everywhere. Actually, it is the commonest chronic childhood disease. International wise 5 to 10, but here in Saudi Arabia could reach 33%. For example, Habu, Najran 27%. Okay, so we usually average in the kingdom 23% as per Professor Alfred. So as you see in here, it is double to triple time the international figure. Asthma is cause morbidity. Asthma is really very costly, especially in severe asthma. The cost will be more than 10 times, especially if you use the biologics. The cost will increase 20 times. So if asthma patient is uncontrolled and has exacerbation and admitted, so the two main causes for the cost for asthma is the hospitalization and biologics. So we are dealing with a disease that is really very costly. Now, is it common? The severe asthma is an average 5 to 10. You might see it's more than this, more than 5, more than 8, less than 5, but this is an average international wise. And you might see in here the 24, we will see now asthma, the severe asthma, there are certain classes, class 1, class 2, class 3, we will see through it. Even in a summary, the severe asthma, 5 to 10. Now, if it is only 5 to 10, so why you are presenting in this group and you are lifting the 95%, because the 95% will be easily controlled with education and mild dose of inhaled steroid plus or minus the LABA or montelukast. And here we are dealing with a group that's really very costly and very risky. So now, what is the best approach? These are the 7 steps that I would like you to know. I need to confirm the diagnosis. Then I need to know what's the class of severe asthma. Then I need to confirm whether this patient is controlled or uncontrolled. Then phenotype, then assess the biologics, then re-evaluate as you see slide by slide. So is this patient asthma? Asthma is a clinical diagnosis. Any child is coughing late at night, early morning with exercise, seasonal, okay, or a residual cough, post upper respiratory tract infection. This is an asthma. If you want to confirm it, if patient is able to do the BFT, yes, you can do it through the standard spirometry, looking for FEV1 reversibility by 12% or mid-expiratory airflow by 30%. If you have really the facility of pheno, yes, it is an easy test. You can look for high pheno. It is supporting a patient to have asthma. So asthma is a clinical diagnosis, but can be confirmed in a lab with a facility of BFT or pheno, for example. Okay, now, what is the classification of severe asthma? 3 classes. Class number 1, severe asthma, but he didn't receive medication, okay? Class number 2, yes, patient is severe asthma due to contributing factor. Father is a smoker. Patient has allergic nose. They have cat at home. So there is adherent problem or technique problem. Okay. Now, class number 3, patient is still symptomatic despite class 4 or 5 SINA, GINA or other guidelines. Okay, and you control all these contributing factors, and your patient is still symptomatic. As you see in here, it could be reaching an average the severe asthma around less than 4% of the asthma in general. So now, so class 1, patient didn't receive treatment, and actually these are not seen because if patient has symptoms of asthma, he should be on medication. Now, the commonest type of severe asthma is class 2. Class 2 in here due to either inadequate doses. So, are we treating over-treating asthma or under-treating asthma? In literature-wise, everywhere we are under-treating asthma. Okay. For example, Europe, 45% meet the criteria for well control. Canada, in general, less than 25%. South Africa is less than 10%. Here in Saudi Arabia, okay, I would say, so the message in here that asthma is still causing mortality, morbidity increasing. So in here, I just finished a project in military hospital and submitted. Okay, we found in military where there's almost 7 pulmonologists. Okay, still more in younger age group, more than 50%, 51.2 is still uncontrolled. While older age group, 34% is still uncontrolled in tertiary center, where is the pulmonologist available. So just imagine this one in a tertiary center. But is this different from what we have done before? 10 years ago, I have done the same study in King Fahd Medical City, and I found 45% is still meeting uncontrolled. Uncontrolled asthma is still uncontrolled. Just imagine this is King Fahd Medical City, military hospital, where is the pulmonologists, and they are big tertiary center in the kingdom. Okay, but imagine the north part of the kingdom where there's almost no pulmonologists, just newly graduate pulmonologists in that area. So what we are expecting the asthma there? Okay, so definitely is poorly controlled. So the message that still asthma is still inadequately treated everywhere. Okay, now we will move to the compliance. Is the asthmatic patient, we are treating asthma for 3 months. Okay, so generally more than 50% they are poor compliant. Okay, and even sometimes in literature only 14% or so we are coming in the right time for taking the refill medication. So again, compliance is a big problem. Now, is it a technique problem? We are prescribing the medication. You have a huge number of asthma in the OPD, but you are not treating them. You have time to explain asthma. So the technique, I have seen many patients, they are taking the inhaler direct, which is not allowed. So it's still wrong technique is very still common, on average 80%. Just imagine this one. So yes, we are giving the medication. If not, they are not giving the medication, it's still a technique problem. But if you now give medication, you have patient stress about importance of the compliance, and you educate them to take it in the appropriate technique, still there is a risk factor, contributing factor at home. Father is a smoker, patient attend them daycare. They have cat, the house is full with grasses, seasonal. We have large families, large countries. So these are risk factors really very important. You need to control it, okay? Or smoke. Smoke is very important. I'm not smoking, I'm just using vape. It's the same, okay? So now, if you get rid out of this, now the contributing factor, risk factor at home, still comorbidity. So 20 years ago, I'm treating asthma as asthma, but nowadays I'm treating asthma and allergic nose. Asthma and allergic nose called United Airway Disease, and the problems of the asthma just often started with the nose. So I'm putting a major effort in treating the allergic nose because it can help, okay? And younger age group is reflux. Reflux is very crucial. Now obesity is getting increasing in the country. I would say the school age is more than 50% of the kids now, they are obese, and obesity, there is a strong association with asthma, allergic conjunctivitis, eczema, and sometimes if I stuck, okay, my patient is still asthmatic and he's not controlled, I will blame the vitamin D, which is vitamin D can help to control asthma. Now, if everything is fine, you give now good medication, you educate the family, The clinic is fine, no risk factor, no comorbidity. So you need, maybe your patient has wrong diagnosis called asthma mimicker, and this still can be counted in around 20%. We just published, actually a few years ago, about this group, okay, of asthma mimicker in the International Journal of Pediatric and Adolescent Medicine, which is highly recommended for general pediatric when asthma is not guilty. When the patient is coughing, but is not not asthma, for example, sinus, okay, and others. Now, your patient still has symptoms. You need to confirm that he is what? He is severe asthma, okay, and he's still symptomatic despite the appropriate asthma therapy, and either through the asthma questionnaires or through history of frequent exacerbation or BFT, for example, pulmonary function test is with reduction in the spirometry. Now, yes, your patient is now still asthmatic, okay, confirmed with the BFT that he's still struggling, he's still having recent admission and requiring, for example, steroid or frequent use of bronchodilator to relieve the symptoms. So now you need to think about alternative. So this is now the era that you need to think about the biologics. So for the biologics, you need to know what is the phenotype and endotype. Phenotype, just simply what is the clinical classification, interaction between the patient and the environment. So is he allergic asthma or non-allergic asthma? Okay. The endotype is subgroup of the phenotype. Okay, so this is more specific and more accurate. Okay, this is at cellular level, but these are really sophisticated and need an expert and need lab. So I just, to make it more simple, okay, I like this diagram, and there's some modification. This was published in 2016, but I add some on this table. So asthma in general, is it, you need to classify it according to the immuno response. So is it allergic asthma or non-allergic asthma? Majority of asthma is reaching 70% is allergic asthma. So this is called now T2 high, okay, or eosinophilic asthma. And now the other group, which is minority, which is sometimes the difficult group to control, is called non-allergic asthma or T2 low or non-eosinophilic asthma. And for the eosinophilic asthma, the T2 high, there is certain mediator or biomarkers, biomarkers that can be helpful screening for your asthma. Example, eosinophil, whether in the blood or sputum, or IgE level or pheno, okay? And these, and the T2 low, the neutrophilic or the posigranular or mixed, okay? So these biomarker will work at cellular level. For example, nasal epithelium, okay? And will work on the certain important mediator, okay? Eosinophil, muscle, and etc. So these require certain cytokines to show the inflammation and the cascade of the asthma inflammation. We will touch in it. So now, if we block these cytokines, we will block the inflammation, and we are expecting the asthma will improve. And as you see in here, this is called anti-L5, anti-IgE, anti-interleukin 4, and interleukin 13. In the neutrophilic asthma, this is a minority. So there is just maybe just one, as we see, anti-TSLP is the only approved biologic in this area. Now, so this is just an introduction for the biologics. So biologics is area of development in the treatment of asthma. It is add-on for step 4 and step 5. And you will hear now what are these biologics: omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab. And we will see now what are how to choose it and what are some important message about each. So before going now to choose these biologics, you need to know markers. Even the most important is the sputum eosinophil, if the patient is able to expectorate, or blood eosinophil more than 150, or pheno more than 20, or total IgE. So these are really very important markers for eosinophilic asthma. If not, you can say this patient is neutrophilic asthma, for example. There is other mediators, but still under investigation, okay, and can be used. So the majority is the eosinophilic asthma, and you have the markers there, okay. The best is sputum, but the kids majority are young and they are not able to expectorate, okay. So we are going often with the eosinophil in the blood, or pheno, or IgE. And the eosinophilic, for example, IgE or skin test, okay, so this is give you certain biologics, okay. And I would say this is probably might be just needed for the subspecialty, okay. So the neutrophilic asthma, I told you in here, this is the only anti-TSLP, macrolide, LAMA, okay. So they have plenty of choices for the eosinophilic asthma, while it is very limited for the neutrophilic asthma, and still nothing yet for remodeling in literatures. So I would say here, this is really very important slide. Why? Because this could explain what is the mean of T2 low, T2 high, allergic eosinophilic asthma, and eosinophilic asthma. So if patient, for example, inhaled aeroallergen, so it will be detected by the antigen-presenting cell, like dendritic cell. So will stimulate T helper. So the stimulation of T helper will differentiate in T helper 1, T helper 2. And this T helper 1 plus with the T helper 17, this is called neutrophilic asthma, or this is T2 low. While the T2 high, okay, through certain mediator, this is very important. For example, it will throw the interleukin 4, okay, will stimulate B cell to plasma cell to secrete the immunoglobulin like IgE, and the IgE will bind the mast cell to mast cell, will degranulate and will cause cascade of inflammation. So now, if we talk about the first biologics, omlizumab, okay, it is work in the bottom of the cascade of inflammation, in the as you see in the bottom of the cascade of inflammation. So now the new biologics, they would like to work in the upstream, okay, like anti-TSLP. So in here, because why? Because it will prevent majority of the inflammation. So now, as you see, each one has each biologics work at certain site and certain cells. Okay, for the first, for example, the interleukin 5, which is really very important one, work in eosinophil. The 13 eosinophil plus the airway. This is again the innate lymphocyte type 2, and this is non-antigenic presenting cell will cause similar inflammation. This is cause T2 high inflammation. So these are the biologics. The first biologics being published was Xolair, even 2002. Then mepolizumab 15, deslizumab 16, then ranizumab 17, dupilumab 17, and the last one is tislelizumab, okay, 21. Okay, so now these biologics, you might see the evidence of benefit in 2 weeks, for example, at the pheno and eosinophil. And you can really assess the benefit at lung function or level of asthma control for 4 to 6 months. And you need to observe potential side effects, especially the allergy. Now, the first medication now being approved in literature, which is called Xolair, omlizumab. Okay, so approved for kids more than 6 years, and it's actually now the lowest cost. And in here we are depending on the IgE level. Okay, it's approved, for example, for food allergy by 1 year, and the urticaria for 12 years. Okay, so depending on the IgE level and the weight, and the calculation will give you the exact dose. This is very effective, okay, and it's proved, and the anaphylaxis here, and it's very low, less than 1%. You might see some other serum sicknesses or cardiovascular complication, which is really very low. But this is the first what? first biologics approved, but usually more than 6 years. As you know, 75% of asthma is less than 5 years. Okay, so we need other biologics. So the other biologics is mepolizumab, which is the one approved in 2015. So this is work on eosinophil. Okay, so the interleukin 5 stimulate eosinophil for maturation activation, okay, and cause a cascade of inflammation. If we prevent the interleukin 5, we will be able to stabilize the eosinophil from causing this cascade of inflammation. Okay, this is the first biologics work on the interleukin 5, and this now given subcutaneous, certain the doses as you see in here. Okay, it's really very effective. The criteria either high eosinophil twice more than 150 or once more than 300 cells. Okay, so anaphylaxis again here, these are the side effects, including the helminth, which is very low. Okay, and this is really again a little bit more costly compared to the Xolair, but it's all the efficacy in all is exacerbation, lung function, quality of plasma control, reduction in the inhaled steroid plus oral steroid being approved. The mepolizumab comes through huge, strong studies, the majority published in New England. Okay, as you see in here. Okay, so this is really very good medication, which is effective in eosinophilic asthma, but again, more than 6 years of age. Okay, so is there any other? This is called risdiplam, approved March 16. Again, work against interleukin 5, but this is again 18 and IV. So there is no much benefit from risdiplam compared to the mepolizumab. Okay, but giving good efficacy compared to the mepolizumab. When you go for the fourth biologics called vinralizumab, okay, approved November 2017, again work against interleukin 5, but also natural killer cell. Okay, so again in here 12 years of age, so there is no much benefit. Okay, to use it in the younger age group. Okay, so can be given 30 milligram injection for weeks, then after that every 8 weeks, and the criteria is eosinophilic more than the same, similar to the others. Okay, so it is again very costly medication. The side effects is almost similar to the others, including the helminth. I didn't put it in here. Okay, but it's also very effective. Okay, this is the dupilumab. I would like to focus here more because I feel it is the best in my little experience because this medication just newly in the market and in the country. So approved again 2017. It's worked through the interleukin 4 and interleukin 13. Okay, for kids, effective more than 6 years. Oh, so I told you majority of the asthma is less than 5 years. So we can use the dupilumab in less than 6 years if patient, for example, have atopic dermatitis. So approved by 6 months. So if your patient and majority of asthma patients, they have atopic dermatitis, you can use it from the second indication. You can use it by 1 year through the eosinophilic esophagitis, but the chronic sinusitis is still by 12 years of age. And the benefit of this biologics can be given at home. Yes, the first time it should be given in the hospital. Okay, and after that can be given every 4 weeks according to the weight, and you decide the best dose, whether 200 or 300 milligram subcutaneous. So I would say this is again a very safe medication. Again, the criteria is still pheno and eosinophil, and this is again more costly. It's 4,600 for each file, and really very effective medication. And further, there is no data that this medication can be used in the neutrophilic asthma. Okay, so still the data here is still weak, but it's promising that it might be beneficial in this kind of group. And the last biologic here is the tezepelumab, which is worked as in the upstream of the of the inflammation, of the asthmatic cascade of inflammation. So it will prevent the dendritic cell, T cells, muscles from degranulation and causing this cascade of inflammation. And the dose is there, as you see, it is 210 every 4 weeks for kids more than 12 years of age, and really effective again. And this is the benefit of this medication. It's approved still in USA 2021, okay, but not yet approved by the FDA, okay. And this what I would say is the only biologics you can use it in the neutrophilic asthma, okay. So this is the summary of what I have mentioned. It's not uneasy to collect the mechanism and age-wise, the route of it, so all given through the subcutaneous except the refluzumab, okay, and the criteria of the eosinophilic or pheno, okay, the minor side effect, okay, in here, just for example, I would keep in your mind the diplomab probably you need to be sure about, because you can use it in younger age group about vaccination, and you should maybe avoid all live vaccine, because this could cause some interaction. And the cost for this medication is there, and this is the tislelizumab this is UK. It's really very costly medication. So this is a summary. So if no good response, I like now to use now diplomab, for example, with education. Okay, so if patient you continue, for example, for 4 months, okay, and patient is still not showing improvement, you might stop the biologic. But if patient improving, you can continue 1 year, 2 years, 3 years, up to 3 to 5 years. The literature prove this benefit. Review the basics again, basic compliance technique, risk factor, comorbidities. Reassess the phenotype and endotype all the time. Sometimes the patient is not doing well while he's on this medication. You should consider the CT bronchoscopy and systemic steroid, and consider the T2 low medication, which is including the azithromycin. So this is a summary of what I mentioned. If patient has, for example, the asthmatic, check if patient has T2 high, then check the IgE level. If the IgE level in range between 30 to 1,500, the main biologic is omalizumab. If the IgE is more than 1,500, okay, check the eosinophil and the pheno. If the eosinophil and pheno is high, you have 2 choices, mevlizumab and diplomab. Okay, so now age is important factor to choose which one, and sometimes you need to look for comorbidity, for example, atopic dermatitis or eosinophilic esophagitis, to decide, for example, which one is the best. Now, if patient now doesn't asthmatic, but he doesn't have high IgE level. Okay, so check the eosinophil. If the eosinophil is high or pheno is high, you have 2 choices, mevlizumab or diplomab, according to the age. And if patient is having low IgE and low eosinophil, low pheno, this is called T2 low, and then here tislelizumab or azithromycin or tiotropium is the recommended medication. Now, new era is talking about the looking for the new biologics as the initiative part of the asthma inflammation cascade. Okay, as I mentioned in here. Okay, and there is many biologics in the under investigation. All these not yet proved to be effective in pediatric or even adult. Okay, and the conclusion for my talk is severe asthma is still challenge to the healthcare provider. Excessive load to the resources. There is some data showing the asthma morbidity and mortality still increasing. There is promising biological data in the last decade. Biologics are still needed. Biologics are essential for the guidance. You need some, biomarker is essential for guidance. Allergic asthma, you have plenty of choices, okay? And initial Xolair, then mevlizumab, and I would say nowadays is diplomab is the top biologics that we are using. Limited choices for T2 low, more biologics under investigation. Biologics are effective but expensive. and I'm expecting a promising future for the asthma. And this is the last slide, and I'm really sorry if you feel that it's complicated or heavy talk, and you are
Yes.
simple answers. شكرا دكتور نبيل.
Thank you, Dr. Abdullah, for your, yes, it is really heavy talk, but it's interesting and it's very updated. So thank you so much. There was just one question from one of the attendees. Have you ever heard about hallucination with the use of singular? Any baby got hallucination?
Thank you. This is very smart question, really. There was FDA awarenesses about the neuropsychiatry and even potential suicidal attempt. And I have a publication about adverse side effect of Montelukast published 2 years ago in Children, okay, journal, which is really very important journal in Europe. Okay, I found the main side effect is hyperactivity, 6%. Then I found the sleep problem is night terror, nightmares. Okay, so cumulative could reach 15. Hallucination be reported, I didn't remember exactly, but definitely less than 5%. Okay, there is some pain. Okay, cumulative could reach 15. So the recommendation from the article give the Montelukast as add-on, but observe the side effect. If there is any side effect, whether hallucination, suicide, hyperactivity, night terror, nightmares, or stop, and often it's reversible. Okay, so if one want to investigate or to look for more detail, what adverse effect of Montelukast, and this is the only articles in the Gulf region.
Thank you so much, Dr. Abdullah, and we can proceed with the next talk, which is complicated pneumonia.
Thank you so much, Dr. Nabil. Just one.
So there is a question from Dr. Ali Abdul Nasser. I can just mention it to you.
I would be happy to hear from my best friend, Dr. Ali. Yes.
With this very costly medication, is it still practical to use them? Insurance company, Dr. Ali, طبعا interested in insurance. Yeah, Dr. Ali, if you will approve, the company will pay.
والله سؤال okay, so really in literature the cost benefit of biologics is not yet proved. If I'm talking about cost benefit of using biologics.
Yes, he's just asking about, do you think that in the future the insurance company will be forced to accept to cover this?
Yes, definitely. Yeah, if this is the guidelines, okay, from everywhere, can be used. If you label your patient as uncontrolled step 4 or step 5, you can even legally, I would say, taking the companies to the court, okay, because we feel it is safe medication and it's effective and recommended by very strong, I would say, institution and references.
If this will happen, I will be happy. I want to take them all to court because they are giving us hard time to approve any medication.
I agree. Even sometimes, even simple, when they hear some congenital or some costly medication, they will get rid out of the patient.
Yes, not covered, not in the policy.
Believe me, I'm struggling with seritide. Okay, seritide. Just imagine seritide, even in Hamadi or in Saudi German hospital. I received multiple, I would say, rejection from the companies about seritide, which is medication can be used in step number 3. Okay, seritide, which is really good medication. Okay, so just imagine if I go further to the biologics. I'm expecting huge resistance, but I would say with time they will accept.
Inshallah. Okay, we can proceed to our next and the last presentation for this day. So, Dr. Abdullah, you are in.
الله يعطيك العافية دكتور نبيل. الرجل النبيل دكتور نبيل.
الله
management of complicated pneumonia. Okay, so I would say would be more simple and live by the pediatrician. I would say the senior pediatrician consultant. Okay, why? Because I'm here, I'm not talking about the simple pneumonia, how to treat pneumonia. And you might look for the guidelines, for example, international-wise community-acquired pneumonia, or even our local guidelines here. I'm talking about complicated pneumonia. So what do I mean by the complicated pneumonia? We will see. So these are the outline. I need you to know certain definition. Then I will give you certain scenario for real cases. Then what are the epidemiology about the complicated pneumonia? Some simple pathophysiology, causative organism, clinical presentation, and as most importantly, how to manage such cases and the therapeutic option. People usually they are interested what is this patient has effusion, and so what is he a candidate for conservative or I need intervention? And what is the best intervention? Is it thoracocentesis, chest tube, or big tail, or the physiothoracoscopy, or decortication? We will go through it one by one. So please listen to me carefully, because I would say I'm one of the experienced. This is one of the area of the interest for me at personal level. So the complicated pneumonia, the best definition in literature I found, this is chest infection complicated by effusion, empyema, abscess, necrotizing, or patient labeled as severe pneumonia requiring ICU, whether ventilated or not ventilated. And as you see in here, this definition is not complete. For example, patient with bronchopleural fistula. Okay, where is he from the, is it really a patient complicated pneumonia? One more thing, patient has bad pneumonia, he has multi-organ failure. Okay, so it's not in here. So the definition, I would say, even literature is incomplete. So I feel this is the best, my definition, so for the complicated pneumonia after, I would say, 20 years plus in pulmonary. So it's chest infection associated with localized finding. Example, effusion, empyema, lung abscess, or necrotizing, or bronchopleural fistula. I add this one in here. Or severe pneumonia requiring the ICU, whether ventilated, non-invasive, or even just any admission to the ICU. Or systemic disease such as septicemia or multi-organ. So multi-organ dysfunction. So I would say this is the best definition and the complete definition. Maybe this is my own view. Maybe people could argue about some new finding that I didn't touch it, but this is the beauty of the literature and the medicine. Nothing is Mr. Perfect, so it will change with time. So this is what I mean, because the definition is very important, because now later on we will what is the best approach for what type of complicated pneumonia. Parapneumonic effusion, when we see fluid in the pleural cavity, while empyema is pus in the pleural cavity. So we will, what is the difference between fluid and pus? We will come through it later on. So now I will give you a real scenario for cases. So this is a child one day in Kilbride Medical City, came with chest infection left-sided with para, a significant left-sided pleural effusion. So the diagnosis here is parapneumonic effusion. Okay, so parapneumonic effusion. So is it conservative or is it intervention? So this patient has intervention with the chest tube, and patient has high LDH, treated with vancomycin, cefotaxime, and patient improved with time later on. But this is called complicated pneumonia, parapneumonic effusion. I put in here first stage. Why first stage? Just remember 3 days illness. Now, this patient is 80 years with fever and cough, but he has 4 days. As you see in here, this patient is having what? Chest infection, effusion, there is absent bronchogram, there is deviation of the trachea. So there is definitely huge effusion in the left side. So this patient is parapneumonic effusion, likely need intervention. But what type of intervention? Oh, later on we'll come. What is the best intervention for such cases? So this is again a complicated pneumonia, but different scenario. This patient is having what? as you see in here, is multiple cavitation in the X-ray, clearly in the right upper and middle zone, and confirmed by what? By the CT. So cavitation, necrotizing pneumonia. Is it conservative or with chest tube, for example? So usually in such we are preferring conservative. There is a minimal insignificant effusion, doesn't need intervention based on the X-ray. So to make it more complicated, this case, 3 years, came to me at one time. Dr. Target the case yesterday presented a good talk. He has done the surgical intervention for this patient. So this patient is having large left-sided lung abscess. Okay, and patient has 3-week symptoms. When I revised the X-rays, I found what? Large cavity in the left side. So the diagnosis here is lung abscess secondary to CBAM, which is called cystic adenomatoid malformation type 1. So how to treat such cases? We will come through it. This patient, even these cases being published in the children journals. Okay, this patient has recurrent lung abscess, again left side. But when we investigate why this patient recurrent lung abscess, we found large feeding vessel from the aorta. Okay, so this is sequestration. So the lung abscess, secondary sequestration. The sequestration, the commonest site and the preferred site is the left lower lobe. So if any patient coming to you with recurrent left lower lobe infection, you should rule out number 1, sequestration. So the last case is an 8-year, 10 days, has large effusion, discharged gamma from King Salman Hospital. The patient was, as you see, looks perfect. She's not interested. Then she went to intervention and she gets more sick. So what is the best? So this patient is likely, this patient called loculated, okay, because this patient or could be reaching the organized stage of the emphysema. So now the conclusion from these 6 cases, the presentation of complicated pneumonia are variable. The management are variable. The outcome usually excellent, but often variable. So what is the update of management of such cases? So I would like you to identify the complicated pneumonia in the early stage, and I would like you to predict what is the best appropriate intervention at appropriate time, and I would like you to eliminate potential complications. So these are important guidelines that a pediatrician should be aware about it. And I spent, I would say, maybe 2 months or 3 months tackling the best guidelines and what is the best writing, the best approach in managing complicated pneumonia, and this published in the American Journal of Pediatrics. Okay, so management beyond guidelines. Okay, so I went even through, I would say, huge number of literatures, but I have selected more than 50 very important guidelines to be filtered, and I have chosen the best for the management of complicated pneumonia. So these are maybe 5 important guidelines for management of the complicated pneumonia, including from the parapneumonic effusion to the emphysema. So ATS, the pediatrician, he knows about pneumonia, parapneumonic effusion. So is it first stage, second stage, third stage? Is it oxidative, hypervirulent, organized stage? So these called ATS, published from 1962. Simply thin fluid, bus, trapped lung. Okay, so this is now the pediatrician, the usually familiar with this classification of parapneumonic effusion. But the father of parapneumonic effusion called Dr. Light. At one day in Sakistas, maybe he was resident, and was teased by his consultant. But he came, a smart physician, he recently died. He's a really senior pioneer physician. He's the one came up with the oxidate and transudate criteria and classified parapneumonic effusion to 7 classes. The class number 1 and class number 2, is it simple or typical? So is it insignificant or significant? It's less than 10 millimeter, which is equal to 1 centimeter, or typical more than 1 centimeter in lateral decubitus film. So the class 3 and 4 and 5 called what? Complicated paranumeric effusion. Borderline, simple, or complex. If we positive gram stain negative and culture negative, this is borderline. If there is positive gram stain or cultures, this is called complicated. Now, if it is multiloculation, called what? Complicated complex paranumeric effusion. And class number 6 and 7, this is called emphysema, whether emphysema, and this is likely by the surgeon, simple or loculated, simple or complex emphysema, depend on the loculation, single loculation or multiple loculation. When we go for the Muir, the Muir is really a smart physician, but he used the light and the glucose and protein. So simple effusion, if it's still the glucose, for example, and it's still normal, and the LDH is less than 1,000. When the complicated, thick, but LDH more than 1,000. The emphysema, when there is bus. And the ACCB, the American, okay, they are classifying the complicated pneumonia based on the X-ray. Category 1, pretty low risk, less than 1 centimeter. Category 2, more than 1 centimeter, less than half of the hemithorax. Category number 3, more than half of the hemithorax. And category 4, which is called BUS. The the British guidelines, clear, cloudy, BUS. So in majority, whether first stage or category 1 and 2, simple effusion, you are in either conservative or thoracocentric. Then when you go for the exudate, hypervirulent stage number 2, you have now plenty of choices. Thoracotomy, whether thoracocentesis, big tail, physiothoracoscopy, then plus or minus the fibrinolytic agent. When you go for the third stage or the complicated or the emphysema stage, you have the limited choices, mainly the decortication. The presentation of complicated pneumonia is simple pneumonia: cough, fever, shortness of breath, and chest pain usually to the affected side. And usually there is, I would say, scoliosis to the affected side by around what? 30%. So there is limited breath sound in the affected side. There is what? Potential crackles. Sometimes complicated, if there is effusion, you will see what? The friction rub, dullnesses in the percussion, the decreased tactile focal perimeters. So these are, for example, the complicated pneumonia. There is mild effusion, there is some scoliosis tower to the left side, and as you see in here, the first sign of effusion is obliteration of the costophrenic angle. Now, the commonest organism is the usual organism, strep staph, but could be others. Mycoplasma, could be viruses, including influenza, COVID, TB, others. Okay, so younger age group, you need less than 3 years, you need to think about the Staph aureus. Older age group, strep is the commonest. So the simple benefit or the simple investigation that be beneficial in the complicated pneumonia is the simple X-ray. Simple X-ray is very easy, it's very helpful, and you can detect for example, the effusion. So the effusion, as I mentioned, it comes first stage in the costophrenic angle. When it is huge, you will see what deviation of the trachea to the other side. Okay. Now, I recommend to use, if you are encounter complicated pneumonia, you should do lateral decubitus film. But when I'm asking the resident to do the lateral decubitus film, they are often, even the radiologists, they are sending me the lateral film. So decubitus film is if the patient has infection in the left side. So you can ask left-sided decubitus film. So the patient should lie on the affected side, and the film should be showered from the back. So this is the the lateral film, as you see in here in the I don't know if you are seeing the pointer or not. Okay, but the benefit of the lateral decubitus film, you see, is it significant or insignificant effusion? So when to label it more than 1 centimeter through the width of the effusion. Number two, is it loculated or not loculated? If you see multiple loculation, so you are dealing often with the second or third stage of the empyema, okay? And this is now later, you need more intervention, whether ultrasound or CT guidance, okay? And you might see the X-ray, you will see huge effusion with deviation of the trachea to the other side. Absence of air bronchogram. You might see wide space between the ribs in the affected side. Is it clear? So this is from the guideline. Chest X-ray is simple, least expensive, and very beneficial. Obliteration of the costophrenic is early sign. Okay, you should do the lateral decubitus film, please. Okay, so I encourage you to utilize the benefit of lateral decubitus film rather than going simply to the ultrasound. So I put the CT before the ultrasound, and if you have the experience, a good radiologist, no, ultrasound before the CT. So CT is really very helpful, but is it indicated in all the patients? No, should be limited, shouldn't be used as routine. It's an excellent to evaluate the lung parenchymal and loculation. It is very beneficial as guidance for the interventionist. For example, if you decided to call the interventional radiologist or the surgeon before intervention, for example, the PADS, okay, and it can differentiate between the pleural thickness and the effusion. So I would say it is very helpful, and I like it, but not all to the cases. Okay. If you think your patient needs intervention. Now, ultrasound can give you the same information that needed by the CT. It can estimate the amount of fluid, can be differentiate, is it loculated, septated, can get, is it thick fluid, thin fluid. It can again differentiate between is it thick pleura or fluid, or so the finding is with the expert similar to the CT, but the problem is an operator dependent. So it depends on the experience of the radiologist. So in here, most of the cases, they are calling me at midnight. I'm not trusting, for example, the junior people doing ultrasound at the level of the emergency, or the junior radiologist and still the radiologist at home. So I like, if I decided to do big intervention for the CT, and this is, I would say, is a personal experience. Maybe people doesn't like it, but the CT will give you detailed anatomy description. So the recommendation here from the guideline, ultrasonography is examiner dependent. It can be used as guidance as well. So echogenicity, that means this patient is having exudate. So I would say it's beneficial, but are you trusting your radiologist or not? This is the questions from my side. So bronchoscopy, we are not often doing it unless, for example, patient is immunocompromised or patient is not sick and we are not getting a clear organism. Okay, so it could be beneficial to look for the microorganism plus what? Looking for neutrophil and the others, okay? But often is not routinely indicated in the complicated pneumonia. When to do the thoracocentesis? When there is significant pleural effusion more than 10 millimeter through lateral decubitus film. So if you decided to do the thoracocentesis, okay, and often the ICU, okay, you need to be sure about pH. So pH is very crucial. The same pH like blood gas, okay? So pH, then through the machine, if it's nearby in the ICU, if it's acidotic, this is empyema. Okay, if the glucose is very low, empyema. If the LDH more than 1,000, this is empyema. Okay, so the cells, gram stain, culture, sensitivity. So if patient has, for example, bloody patient sick has significant effusions, this is likely strep, for example. As you see in here, for example, the pleural fluid, the purulent, thick, start. Butter, anaerobes. Bloody, group A. Now, when to say, if you remember, this is bus if the WBC more than what? 5,000. So if patient has lymphocytic pleural effusion, this is the worst scenario that often encountered for us because the organism here is different. So it could be the infection not related to the effusion, could be lymphoma, chylothorax, TB, uremia, mycosis, or connective tissue disease. So there is limited causes for lymphocytic predominant pleural effusion. So these are really real cases. For example, this case, this is an asthma presented with a chest infection, and when I have this patient being published, okay, as malignant pleural effusion. So when I have done the effusion through by the surgeon, they told me it is predominant neutrophil. And patient asthmatic, I started steroid, and the patient improved. Okay, so later on, through 2 days after the intervention, the infection is it disappeared, and we are expecting the virus chest infection. It will be take several days in order to disappear. So there is marked improvement in the lung parenchymal infection. So it was malignant pleural effusion. When we revised the neutrophil or the differential, it was lymphocytic predominant, and we missed the mediastinal mass, and patient improved because patient is given steroid, and we missed in this patient as well hepatomegaly. So lymphocytic predominant pleural effusion, you should think about lymphoma, chylothorax, TB. And this is, for example, renal case. This is Down syndrome of chylothorax. So this is the light criteria. As I mentioned, this is the famous physician that he was behind the criteria for when to say exudate or transudate. Thick, high protein, high ratio of the LDH. This is called the exudate, and the transudate, we are seeing it in the for example, in the cardiac, renal, these are the usual causes for volume overload. So when to say simple complicated parapneumonic effusion, okay, I would say this is simple if it is small. The pH numbers almost near normal. When the patient has really large effusion occupying more than 50% of the hemothorax, loculated or acidotic hypoglycemic high LDH, this is called complicated pleural effusion. There is benefit now of PCR or procalcitonin, and we are in military have benefit of respiratory panel that can be requested initially for a patient with suspected complicated pneumonia. Blood culture should be done. Okay, sputum if patient is able to oxybutyric is very helpful. The goal of treatment now is to treat infection, drain the virulent effusion, re-expand the lung, and eliminate the complication. And all the patients need admission. So in here you are in between conservative or first surgical. Treatment, complicated pneumonia, similar to the pneumonia, okay, but this patient should be in under close observation, but you need to start plus the IV fluid, good oxygenation, good analgesia, double antibiotic, third generation cephalosporin, like cefotaxime, plus anti-staph medication, whether clindamycin or vancomycin. So 2 medications that you need to start with. So there is no benefit of CBT, for example. You need closely observing your patient. Patient need a good nutrition. So is it conservative? Generally, initially start with conservative, unless your patient is getting sick or the effusion is getting enlarged, or you have loculation through your evidence through the X-rays or ultrasound or the CT. So when to do the surgical intervention in this large effusion, multiloculation, compromising respiratory status getting worse. For example, patient is starting to require non-invasive ventilation or requiring, for example, high flow nasal cannula oxygen. This slide is really very important, okay, because when we are dealing to the pneumonia, so day what of infection? Usually the first 3-5 days, maybe this is the simple pneumonia, okay? Then this patient will go for the complication. the first stage, second stage, third stage. So we are dealing now with the duration, less than 5 days, 5 to 10, more than 10 days. So if you remember these cases that I mentioned, so if patient comes to you in the first 5 days, so this patient is still first stage of emphysema. If this is paraneumonic effusion, maybe not infected, it's still thin fluid and easy to drain. Now, if patient comes now with 7 to 8 days, so between 5 to 10 days, so this is likely second stage of emphysema. Now, if patient received antibiotics, which is the usual, so the fluid in here could be thick, like jelly, so might be not drained easily. And now here, the intervention is different. And as we will see now, is it thoracentesis, chest tube, big tail? So in here, often we are going with big tail chest tube. So then look for the BH and LDH, then you will decide if not draining well, you need to add TBA. Then if patient is not doing well, decortication. Or from the start, stage 2, call the surgeon for the pediatricoscopy. So these are now the potential that I will choose. So thoracentesis, patient, as I mentioned, more than 1 centimeter lateral decubitus. Where to go? In the mid-axillary line. Okay, remember, it's initially diagnostic and therapeutic. Okay, so if patient is draining well, take as much as you can, and you can compensate, give normal saline to compensate these fluid, because what? Because it could be already in the second stage. If it drain well, okay, take now glucose. If you have now, if you are working in the ICU, what is the pH? If the pH now is low, okay, if the glucose is low, if the LDH is more than 1,000, the best is to put chest tube. To put chest tube. Then keep the chest tube and see, is it drain or not? Okay, so number one, what? The thoracentesis. Now, chest tube, you need to go for safe triangle. What is the safe triangle? This is called imaginary line at the nipple, lateral part of the pectoralis major, and the anterior border of latissimus dorsi. So put the needle there, okay, or through the manipulation according to the X-ray or CT or ultrasound. And these are the site, and connect to the minus 20, okay? And often in the past we are using it in the ICU. So still business of ICU can be done by the surgeon, can be done by the interventional radiologist. But I think it's still majority doing it by the by the intensivist. Now this big tail and now is getting more popular. It is replacing now the chest tube. Okay, the people, the old generation from the intensivist, they are going with the chest tube. But nowadays, with the benefit of the interventional radiologist, we are using a more simple, smaller needle, so less traumatized to the chest wall, less painful, and giving the same efficacy, especially if the fluid is thin. Okay, and these are the size, the size of the big tail that we are using, and this is done by what? By interventional radiologist. Okay, under guidance, whether CT or ultrasound. Now, if patient is not draining well, and still patient is compromised, or acute phase reactant is not doing well, both the fibrinolytic agent. In the past, we use the streptokinase. In Canada, through my training, using this urokinase. But nowadays, is TBA. Now TBA. And now we are using sometime plus balmosine. Okay, and these are the doses, 0.1 milligram per kilo once daily for 3 days, with indwelling around 1 hour, and see the drain. It's really very effective and very beneficial. And observe the potential side effects like coagulation problems. Okay. If patient not doing well, you can go for, or from the start, patient coming through in the second stage, call the surgeon, because the pediatricoscopy is really very beneficial and minimize the duration of admission. And in the second stage of emphysema, the outcome, this is local study, okay, Hajjar and his group, if I'm not mistaken, outcome is 100%, but still can be used, but the outcome from the third stage is 60, so 67, so 2/3. So decortication is the pedio is still hugely recommended, and nowadays not very sure to start to call the surgeon for the for the second stage. So now you have two choices: either call the surgeon for video or call the interventional radiologist for the big tail. If it's single loculation, call the interventional radiologist. If it's multiple loculation, call the surgeon. Now, if patient comes to you with the late stage or patient is not doing well, the last and the least is the decortication, which is sometimes is open thoracotomy. Now, these are my recommendation. So, patient has paraneumonic effusion, do ultrasound or lateral decubitus, and I prefer lateral decubitus film. If the fluid in the lateral decubitus film more than 1 centimeter, do thoracocentesis. Then if there is a bus, low pH, low glucose, but chest tube. If it's draining well, that's fine. If not draining well, add TBA. Then observe. If not doing well, you have two choices. Okay, the fast or the open thoracotomy. Now, if the fluid, if the lateral decubitus is less than 1 centimeter, this is conservative only. If it is septated or loculated, so it is single loculation, big tail, multi-loculation, fast. So when you put the big tail and fast, there is expected drain, whether big tail or chest tube. So draining well, that's fine. If not, add TBA. If not doing well, decortication at the end. Okay, so at the end, the prognosis is excellent. You need to know about the high risk group, abscess like and pleural fistula, low degree accumulation, pneumothoraces, lung collapse could be important complication. And I think this is really the last slide. The home message: complicated pneumonia is really very common. Duration of the disease very crucial. Image very helpful. The lateral decubitus, I repeat, maybe 5-6 times. Benefit of lateral decubitus film. It's very helpful. Ultrasound is really very helpful with the expert radiologist. Early detection is very helpful. Treatment often conservative. Intervention can be helpful with certain guidance, as we mentioned. TBA is helpful. Early nowadays to call the surgeon, multi-loculation, single loculation, the interventional radiologist, but still patient still be a victim for our personal decision. You need to consult the experts, pulmonologists and others. Case conferences recommended for such cases, and we need local guidelines for complicated pneumonia again. And thank you so much, and I hope that I gave you benefit for such really important subject, which is called complicated pneumonia. Thank you.
Thank you, Professor Abdullah. Really, thank you for your great presentations, and really we enjoyed and learned a lot from your two presentations, and it was فعلا مسك الختام لليوم الثاني. شكرا جزيلا لوجودك معنا، وإن شاء الله دائما موجود معنا كل سنة بإذن الله. ويعني I really يعني it is the last time in the day, but we could not leave. يعني really amazing presentations.
الله
Thank you
يحفظك.
so much.
شكرا لكل جهودك ولجهود الزملاء، وأسأل الله أن يعلي شأنكم، فما تقدمونه يعجز عنه الشكر، وأسأل الله أن يكتب أجركم ويعلي شأنكم، وشكرا لكم بحجم السماء.
شكرا جزيلا، شكرا. بكده نكون أنهينا فعاليات اليوم الثاني من طب لحظة، في سؤال very interesting. دكتور علي بيشكر حضرتك، دكتور علي عبد الناصر.
شكرا لأستاذي وحبيب قلبي دكتور علي الأحمد.
الله يكرمك. طيب بكده ننهي إن شاء الله فعاليات اليوم الثاني من المؤتمر السابع لطب الأطفال وحديثي الولادة المستشفى السعودي الألماني بالرياض. استمتعنا بوجودكم معنا ومتشكرين جدا، وتصبحون على خير. نراكم بكرة إن شاء الله في اليوم الثالث وفي ختام المؤتمر. Thank you so much.